Okay, should we start then? Good evening, all. I'm Dr. Virendra, and I'll be coordinating this session one, which will be a pituitary adrenal session in the Dr. S.D. Bhandarkar Hall. So, with a great pleasure, I would like to welcome all the attendees for this West Zone Symposia organized by the Endocrine Society of India. And the attendees for the today's session will be endocrinologists, endocrine surgeons, physicians, neurosurgeons, and the general surgeons who deal with these adrenals, and the neurosurgeons who are dealing with the different pituitary masses. So it will be a multidisciplinary session, which is specially designed to inspire the talks and develop the skills for these topics. To start with the session, I would like to introduce Dr. Ganpati Bantwal sir, who will be chairing this session. He's professor and the head of the department of endocrinology at St. John's Medical College, Bangalore. He's presently the president of Endocrine Society of India, and he has been the secretary as well as vice president of Endocrine Society of India previously. He is member of different prestigious organizations like ESI, RSSDI, Endocrine Society of America, and he has received multiple awards like RSSDI Oration Award in 2014, Nada Goda Oration Award in 2019, Dr. Sunil Kumar Basu Oration Award in 2019, and he has authored more than 85 papers in different peer-reviewed journals. So I would like to invite Ganpati sir for his presidential message and to kickstart this session. Over to you.
Thank you, Virendra. A warm welcome to you all. Greetings from the Endocrine Society of India. As you know, this is the fourth of the satellite symposium. We have already completed the north, the east, south, and this is the fourth of them. This is actually basically a theme-based. The idea of this satellite symposium has been to enhance the visibility of the endocrinologist with respect to other specialties, and that's why the theme here has been endocrine connections. So we are having connections with the orthopedics, the dermatologists, the thyroid, parathyroid surgeons, psychiatry, gynecology also. And we have a galaxy of stalwarts in the field of endocrinology who are actually participating in this symposium. The topics, I'm sure, have been chosen with utmost care by the team of Dr. Ameya, Sheila, Dr. Virendra. They have actually burned the midnight oil for this, doing this great job. I'm sure you will have an academic feast. Wishing you success. And last but not the least, maybe next time when we conduct, we wish to see you all in person. Thank you, one and all.
Thank you, sir. Now, Dr. Amol will moderate the session. So, Dr. Amol Bukan is an endocrinologist who has completed his DM endocrinology from KEM Hospital, Mumbai, and he's presently practicing as consultant endocrinologist in Aurangabad in Maharashtra. Amol, sir.
Very warm welcome to all. I would like to invite our chairpersons, Dr. Padmavati Menon Madam and Dr. Ganpati Bantwal sir. Dr. Padmavati Menon, she is one of senior endocrinologists and one of great teachers we have in endocrinology. She is a former professor and HOD Department of Endocrinology at St. G.S. Medical College and KM Hospital, Mumbai. She was also former professor and HOD Department of Medicine, LTMG Hospital, Mumbai, and she has a teaching experience of around 40 years. So next slide, please.
So, Menon ma'am, you can introduce Nalini ma'am now, because next talk will be delivered by Dr. Nalini ma'am.
You have unmuted me? Yeah. This is a session on pituitary and adrenal, and the opening batsman is Nalini Shah, currently emeritus professor, but she was a professor endocrinology at KEM Hospital, and she is a very good academician, very good teacher, and you all have heard her number of times, and she is going to talk to us about the Cushing's. See, now the heading is not there. I need the. She's going to talk on. Can you all help me out here?
Yes, ma'am.
Cushing's disease case conundrum.
Case presentations or case orientations. I had kept my program ready on the dashboard, and that is now missing. Sorry, Nalini. So you could start your talk on Cushing's.
May I share the screen, please?
Yes, ma'am.
Right. Good evening, ladies and gentlemen. It's a pleasure to be invited as part of the symposium under the auspices of Endocrine Satellite Symposia coming from West Zone. And I kind of would like to start in this adrenal pituitary session, which is being put together very effectively along with numerous topics which are of great practical interest. What I'd like to start with is a case-based discussion in patients with diagnostic challenges associated with Cushing syndrome. I think Cushing syndrome is one of the most humbling experiences that an endocrinologist can go through. And it kind of just continues to challenge you and question all the learnings that you have accrued over the years, only to tell you that you have to de-learn yourself and start relearning the process all over again as the new paradigm shift in thinking in terms of performances of various test parameters emerges. The accent in today's talk and today's symposium is going to be on diagnostic challenges and how does one effectively put together known characteristics based performances of various tests which are available to be used in these patients with Cushing syndrome. Why is it so difficult to look after the patients with Cushing syndrome, and why is it so difficult to in fact make the diagnosis early on without much of the morbidities accruing in these group of patients? Well, the answer lies in the fact that the most hardcore science, as we are aware of, as put together very effectively by David Aaron in this landmark publication in 2010.
Sorry to interrupt. Sorry to interrupt. Your slides are not visible, ma'am.
My slides are not visible?
No, no, ma'am.
Just a second. Can I just restart?
Yes, ma'am, please.
Just you close your presentation and open your presentation just now.
Just a second.
Ma'am, open a new window and open your presentation there, then you can share it. Yes, now it is visible.
Is that okay now?
Yes, ma'am.
Yes.
Lovely. Right. So I was I'm sorry about that little mishap. I think it's pretty understandable that when we're talking about The signs which has got maximum likelihood of possibility of it being a Cushing syndrome are rather late signs in terms of muscle involvement, skin involvement, bone involvement, and hypokalemia. And we really don't want to wait for that late accrual of symptoms or signs coming up to give us a validity of patient having Cushing syndrome. It's far too late to get into this kind of state of morbidity. But when we talk about early onset of disease and early diagnosis, it's even the patient doesn't feel the need of sort of, putting together a medical consult at this junction. So if we kind of put this whole serial picture of this particular patient, the Cushing has started at this particular junction point, but she presents to us somewhere here a lag period on an average which spells and runs over at least years, if not months, in these group of individuals. And late presentation is one of the problems that we face in all these patients with Cushing syndrome. So putting together this kind of early diagnosis comes only under certain patients who are under regular monitoring after the effective treatment modalities have been put together, as I'll just come back to in a little later part of presentation. Also, some of the patients with Cushing tend to run a very, very mild and indolent course, like this particular lady who just presented with chronic state of anovulation. And because in 20, she was contemplating marriage and fertility being a consideration, medical attention was sought. There were no other symptom complex, but running backwards in her history, it clearly spelled out and showed that right at the age of 10 years, she had started sort of so-called symptoms and signs of Cushing syndrome, but they were so mild that she had never sought medical attention for a nearly period of a decade. So that could be another challenge in presentation of these group of individuals. And of course, at the absolute other end of the spectrum lies a patient who presents to you with a questionable possibility of Cushing syndrome, one of the common basket diagnoses of obesity, irregular cycles, hirsutism, and or presence of hypertension, a so-called metabolic syndrome, which is so very prevailing and common in our clinical practice, that weeding out a possibility of Cushing syndrome from these patients who could be just a larger picture and a much larger number of metabolic syndrome becomes a major diagnostic challenge, because you would have to screen a very large number of patients to pick out these group of individuals. And we can never ever forget these group of state of functional hypercortisolisms, which come from a very large number of psychiatric problems like depression, for example, or other medical conditions like chronic stress, chronic ill health, or alcoholism, where much of the symptoms and signs of Cushing syndrome can be present in these group of individuals, posing major challenges in diagnostic application of various test parameters, which are truly stretched to their limits because it is truly a state of functional hypercortisolism. So when we are talking about diagnostic tests, we are talking about an extraordinarily mixed bag of patients with varied problems and questions associated with the answers that need to be generated through multiple tests. At one end of the spectrum, we have this very, very florid patient with Cushing syndrome, where it really doesn't matter which test we apply. Every test is going to outperform its validity and in terms of its performance. On the other hand, if we start looking at patients who are early Cushing or very mild Cushing, we are now asking for a very, very sensitive parameter of test. And in this, patients with metabolic syndrome and polycystic ovarian syndrome, we are now talking about a test parameter which must not burden the system with a huge amount of false positivity. And here is an individual on a state of functional hypercortisolism, where we are asking for both the test has to be sensitive, and the test has to be specific as well. So how does one deal with it, and how does one select the test amongst the various parameters of tests which are available to us, all of them pretty well known to us, and how do they kind of perform in different case profiles? So when we are talking about this patients which are very mild or early onset of Cushing, and we are looking at possibly very sensitive test parameter to be used, we are now asking performance of various tests which are available vis-a-vis their sensitivity and hence negative predictive value. So when we talk about very mild patients of Cushing syndrome, and as in this particular publication, small number of individuals, but the prerequisite being every one of them having normal urinary free cortisol, telling us thereby that these are very, very mild Cushing syndrome. And there they looked at performance of nocturnal salivary cortisol in serum, in saliva. And per patient, the number of data that was generated was huge, anywhere up to 40 to 45 test parameters which were done per patient. And this was asking two basic questions. What is the sensitivity of this parameter, and what is the reproducibility of this particular parameter? Well, even when UFC is all lying within the normal zone, as can be seen in every single patient, LNSA is going to show abnormality, but it ought to be registered with us that the same patient could have a variability of performance with a completely normal number generated in LNSC, as can be seen in this particular zone of patients all along. So it does have variability in terms of its performance characteristics, but it's one of the very sensitive tests to work. Also, when we talk about our own experience, which is our published data put together very effectively by our moderator, Dr. Amol Bukhar, and when we see it, we kind of had this consistent performance, both in terms of accuracy, which is sensitivity, and the specificity of the test vis-a-vis Cushing's patients, the healthy subjects, and the obese subjects, which is well spelled out in terms of its discriminatory power. But this is the stellar presentation coming from our own country that I'd like to emphasize on. This is a very nice publication put together from Trivandrum, effectively by Abhilash Nair and Nandini, under the leadership of Dr. Jabbar, and it puts together the normative range of LNSC in a community-based individuals across the lifespan of these individuals in a relatively large number. Not only that, they did it on a much more commonly available platform vis-a-vis ICLEA, which is something which is more easily available to us compared to, say, for example, LCMS. And they clearly put together a parameter of 97 centile, which would then allow us to judge the performance characteristic of salivary cortisol in patients with suspected Cushing. But what needs to be realized is that there is no uniformly agreed upon cutoff, and practically every study through ROC has generated their own cutoff for performance characteristics in patients with Cushing syndrome, which is suspected. Our own other parameters of test, like overnight dexamethasone suppression, did have a good discriminatory power in terms of its sensitivity, where it is used in patients at the cutoff of 1.8 microgram, and it generated a number of 99%, which is what will allow us to generate a huge negative predictive value associated with this particular test. And that is the test parameter in terms of its performance, which truly helps us in monitoring a patient who has been operated from transsphenoidal surgery, whom we need to monitor closely because we all appreciate the recurrence rate in these group of individuals. This are the patients who teach us the value of a test performance much before the clinical signs or symptoms prevail in these group of individuals. And it is very clear, much before the rest of the parameters become sort of positive, the diurnal rhythm-based test, which is midnight cortisol, becomes positive in these group of individuals. And at this junction, patients are doing very well. They do not have any symptoms and they certainly don't have any signs. But it takes time for tests like dexamethasone suppression to become positive. So when you're looking at the test performance in these group of individuals, sensitivity wise, it is diurnal rhythm of cortisol, followed by overnight dexamethasone suppression test, followed by urinary free cortisol, as it is shown in this particular patient, where clearly right from diurnal rhythm, which was first test to become abnormal, to overnight dexamethasone suppression to UFC, which can be clearly shown in as a marker of sensitivity of the test performances. So when we are talking about now this group of individuals with the objective all along is not to create a huge burden of false positive test parameters. We ought to be looking at a test which is very specific in terms of his performance. And which test would we use for that? Well, way back somewhere in 2008, Picori Giraldi and their group have compared specificity of multiple tests in outpatient setting in group of patients who are sort of mixed bag of diabetes and metabolic syndrome, and clearly suggested that UFC has almost 90% plus of specificity. Test which is fairly difficult to be carried out, at least in our own experience in our group of patients. So specificity wise, diurnal rhythm doesn't perform well and UFC performs the best as per the literature. Our own experience, if we try and collate in 1,000 subjects with metabolic syndrome and type 2 diabetes, it clearly showed that overnight dexamethasone suppression at the cost of maintaining the sensitivity still continues to offer 96% of specificity, which is a very good number to work with. And those numbers which are falling in the zone of false positive can be effectively taken care of by subsequently using 2 days classic dexamethasone suppression test, which generated nearly 100% of specificity, which is very useful, especially in outpatient setting where we want to apply the patient in this large cohort of so-called metabolic syndrome. So the caveat would then be to appreciate and respect the confounders which can creep in to mar the performance of a given test, like in our this index patient, which we showed all along as a questionable so-called metabolic syndrome, where we needed to exclude a possibility of Cushing syndrome based on this mooning and weight gain, which was her presentation. Her overnight dexamethasone suppression test came out to be 5.3. Now, because the clinical suspicion was less in this particular individual, further detailing of the history and confounding factors clearly showed that this patient at the time of generating results of ODS was on OCP, and that would effectively compromise the performance of this ODS. So the repeat test, after taking care of making sure there is no OCP on board, clearly showed that there was no Cushing syndrome. So looking at a possibility of CPG-based abnormality and CYP3A4-based abnormalities, which are generated by multiple drugs, is one of the prerequisites when DEXA-based tests are being used so that their performance doesn't get compromised. Talking about this particular individual at a functional state of hypercortisolism, our requirement would be to ensure that we do not give him a false label of Cushing, but at the same time, we do not want to miss a Cushing also. So we look at a possible sensitive and a specific test parameter. How do we generate that? Well, let's start looking at some of the data as it is available to us. Various tests like UFCs, circadian rhythm, low-dose dexamethasone suppression tests are fairly specific depending upon the kind of cutoff that you use in these group of individuals. But the minute you start using these cutoffs, you realize that these dark black dots who are actually Cushing are being missed because of this cutoff, which is raised to the bar of 100 nanomoles per liter in this group of individuals. In these suspected patients, if we now use a test like dexamethasone suppressed CRH stimulated test, it is fairly sensitive to take out these patients and effectively prove that they do have Cushing's syndrome by using DEX-suppress CRH stimulated test, which gives you sensitivity at the cost of not compromising the specificity of the test. And how did we do in our own patient? Well, this particular individual, his test, as multiple tests were offered to him to ensure that we did not have a sort of uniform performance was being asked of these parameters to kind of generate the level of confidence to label him as Cushing. And you can see that every single test, which is UFC, midnight cortisol, salivary cortisol, and ODS, all of them generated numbers to suggest Cushing. But when we applied 2 days classic LDDS, it was suppressed. Patient did have depression, and the decision was taken to continue to monitor him clinically and not subject him to further diagnostic parameters in terms of localization, because we ought to be very careful and respectful of the fact that once we take out the bar of diagnosis of Cushing, localization can be very difficult to interpret in every single patient with Cushing unless the first fundamental question is clearly answered. Talking further about performance of DEX-suppressed CRH in these three ladies where the clinical suspicion of Cushing was higher compared to the previous patient that we showed you. And we did show you that this patient also had LDDS. All three of them showed it as suppressed number. But because the clinical suspicion was so high, each one of them were further studied with DEX-suppressed CRH stimulation. And what was seen clearly is this lady effectively suppressed, did not stimulate after the suppressed value on DEXA by CRH. But these two ladies did show stimulation of cortisol as a number after CRH was administered. And both of them were operated, and there was huge clinical outcome-based improvement in both of these patients with histopathological diagnosis of Cushing that was proven as Cushing's disease in both the patients. So when we are talking about test performances, and when we are talking about the different parameters under which we want to evaluate these tests, we are talking about a test which must be reproducible, to have a discriminatory capacity, and it should be very easy in conduct being carried out on the outpatient basis itself. So UFC performs rather poorly amongst all the fronts which we are putting together as our wish list. The circadian rhythm, either as a midnight cortisol, is again a difficult test in terms of its performance, though it is very, very sensitive. It is not specific. On the other hand, salivary cortisol is pretty optimal in terms of its discriminatory power, and it is very simple and effective to be carried out on outpatient basis also. But it is poor in its reproducibility. On the other hand, the overnight dexamethasone suppression test performs rather well on all the three fronts, a point which has been further proven very effectively in one of the recent publication as well. So the old gold standards, which were UFC and midnight cortisol, ought to be replaced in our thinking with salivary cortisol and overnight dexamethasone suppression test, a point which is proven again in this publication of JCNM 2020, where the sensitivity of overnight dexamethasone suppression test was very good, and the compromisation of specificity did not come to, which stood at 90%, which is fairly effective. So again, when we are putting the test challenges together, any test is going to do very well in this particular lady. But in these two patients where we are wanting to have very sensitive test parameters, we ought to be working with salivary cortisol or overnight dexamethasone suppression test. In this patient, where we want no generation of false positive data or keep limited number of false positivity, in terms of enhanced specificity, we are talking about again ODS or LDDS in this group of patient. In this patient, where we want both sensitivity and specificity that should not be compromised, we may have to enhance our test menu with an addition of LDDS CRH as well, is what we need to be sort of conversant with. Now talking about localization, but the prerequisite at every point in time ought to be that we have definitely confirmed that this is a state of endogenous hypercortisolism, because none of these test parameters will have discriminatory power to suggest otherwise, and they will all lead towards diagnosis of Cushing's disease in weakly put together diagnosis of endogenous hypercortisolism. So ACTH, which becomes a major discriminator, does it truly have the power of discrimination? Let's understand this. This various adrenal pathologies, as they go across the lifespan of an individual, each of the disease state is represented and asked for in terms of being ACTH independent. But is it truly ACTH independent? Look at this ACTH number. It is really running all over the place, and it is also not suppressed in multiple patients who are actually adrenal-based pathologies. And in particular, adrenocortical carcinoma, there are a group of individuals where ACTH does not hold this discriminatory power. Here is this group of patients as a representative sample, each of them having a huge mass, which is unquestionable, and look at their ACTH as a number, are hugely elevated and far from suppressed as a number. And there are multiple reasons why ACTH may not have that discriminatory power. One of the important caveats being a possibly positive bias, depending upon which assay you are using, over a assay which has a negative bias of estimation. And there are several other reasons which we may not be able to go through as of now, but this is that we ought to be very, very aware and conscious about before we label somebody as ACTH independent. And when we label somebody as ACTH independent, the next set of performance that we are looking forward to is coming from CT scan. In a unilateral pathology, CT scan sort of performs brilliantly well, and hardly ever we would get into a performance-related problem with CT scan. But when we talk about bilateral adrenal pathology, and especially as it relates to micro, or even for that matter, macronodular ACTH independent pathology of adrenals, one needs to be conscious about it, because these are unusual cases and one sees far less of this as a cohort compared to the other group of individuals. And the ACTH, the CT scan based adrenal visualization in these patients can be very, very different. Like in this patient, which kind of looks like bunch of grapes or a kind of ginger-like appearance, to this patient who has a very normal or in fact smallish looking adrenal, but a very distinctly beaded appearance. So one needs to be slightly conscious of this performance characteristic of CT scan as well to pick up these patients, because obviously the management is going to be extremely different in them. Whereas ACTH dependent pathology necessitates that we go through MRI, and MRI ought to be done under very specific set of characteristics. A macroadenoma never poses a challenge in its diagnosis, but a microadenoma cannot be subjected to a routine MRI. And it means that we ought to be on same page with radiologists who's committed to give us lot of parameters of MRI which are fine-tuned to generate the yield of MRI, which is far superior to the routinely carried out pituitary-based MRI. And in our own series, just mere dynamic contrast-related performance of MRI and specifically designed wide sequences, the performance is seen to be believed. But always there will be a need of generating more invasive test parameters in patients when you run into dilemma like IPSS, described in late 70s and published in 77 and 81, further fine-tuned with CRH to enhance its discriminatory power. And in our own cohort of so-called MRI equivalent equivocal data, it did have its performance, which was tried and tested, and the CRH stimulated IPSS is the only way to go forward, and truly unstimulated IPSS does not have a role, being so invasive and yet being very compromised in its outcome. There are several publications from our own country which have judged the parameters of performance related to also vasopressin and have generated data to suggest that it is pretty effective. Again, I think we need to accrue larger number to put together those patients who may not perform very well, because beyond IPSS, things can become extraordinarily limited to discriminate the possible site of lesion. And here is the example of that. This is a lady who's clearly Cushing, and she is ACTH dependent. And this ACTH as a number does not have a telltale sign to tell us whether it is ectopic or pituitary in its origin. The IPSS, which is stimulated all along, is very, very flat in its response and doesn't show any rise in ACTH post-CRH. So we went back and looked at our IPSS data. It was well cannulated data as shown by these two parameters. Also, the ACTH rise at periphery after the CRH stimulation was not as marked as in patients with central Cushing's disease. And there was practically no suppression on LDDST with cortisol as a number. And that all meant that it was probably an ectopic syndrome of ACTH secretion that we were dealing with. And that's where an effective experience of looking at CT and putting together the DOTA-based imaging data comes together. And the complete credit of that discriminatory power of learning goes to my brilliant postgraduate Manjunath, who very effectively taught us that CT has a very good sensitivity, but it kind of has a problem with its specificity because it generates a non-specific data as well, whereas DOTA has a positive predictive value, which is very, very good. So combination of the two will take us through the localization very effectively. And this is where we kind of generated our own value of localizing in this lady. There was all along in CT scan this bright little spot which was sitting in her abdomen and on the lower abdomen, almost in the pelvis. But when DOTA kind of enhanced it so effectively, it was very clear that we were dealing with nothing but an appendicular carcinoid in this patient, which was a source of ectopic ACTH secretion. And here is the story of success of just putting together laparoscopic appendicectomy and completely curing this lady of her future problems associated with Cushing. So as we kind of go through various test parameters, here is the icing on the cake, which has been generated from PGI Chandigarh, a wonderful study which talks about gallium-68 label DOTA coupled with CRH, which effectively homes in onto the CRH receptor onto pituitary tumor and localizes very effectively in patients who are MRI negative or even empty cella syndrome, and allows you to sort of localize the lesion to the pituitary, which was surgically proven and histopathologically proven and followed up to suggest cure as well, which is one of the very good data which is generated by Ramawalia and Anil Bansale and their group from PGI, published in JCNM 2020, and it's a publication to be proud of. Much as we continue to learn from performance of various studies and kind of de-learn and relearn the process, I think one thing stands the test of time. The collective wisdom of brilliant colleagues and absolutely outstanding postgraduates is what allows you to effectively navigate in this very difficult patient group of Cushing's syndrome to clearly spell out where is the lesion to produce that particular clinical enigma. Ladies and gentlemen, thank you very much for your attention.
Nalini, that was an excellent presentation. Can you all hear me? Can you all hear me, please?
Yes.
Yes,
That was an excellent presentation, and people who have worked with Cushing's will know what kind of problems we face from time to time. And are we allowing questions here or later on?
Later on.
Later on. Okay, so then we go to the next talk. The presenter is Dr. Anurag Leela. He is going to talk on prolactinoma, newer insights. He is a practicing endocrinologist at LH Hiranandani Hospital, and presently, why is this professor of endocrinology at KEM not mentioned in your slide? Okay. He's also attached to KEM Hospital as professor of endocrinology. Anurag, for you for talking on prolactinoma.
So, Virendra, can I share my slide, please?
Yes, sir. Yes, sir. 1 second. Yeah, please share this.
So, Menon ma'am, this is the introductory slide, ma'am. Menon ma'am is muted. So, good evening, everyone. I'd like to present the data of what we have learned at KEM Hospital while managing the cases of prolactinoma. And I'll be sharing the published work as well, whatever we have worked in the department will be shared. I'll try to take it through the physiology and the pathological aspects, and what is interesting to an endocrinologist is what will be taken through in next 25 minutes of my talk. So hyperprolactinemia, the first slide I would just like to say the analytical aspect is a macroprolactin, which is 150 kilodalton as against the 23 kilodalton of a monomeric prolactin, which has a longer half-life. Hence, the prolactin may be higher in these cases. So we have to do, short of the gel precipitation technique, which is not usually available. It goes hand in hand if we do a peg precipitation. So peg precipitation test is usually available these days, and we can easily rule out a macroprolactin in that case. Going to the true high prolactin, so the physiology, what we understand, TRH is a positive stimuli to the prolactin, and hence clinically that is what we have seen in many of our hypothyroid patients. With the TSH going high and the TRH going high, the prolactin will be high, and they have multicystic ovaries in these cases and a pituitary lactotroph hyperplasia. And same was used in the past to differentiate a normal lactotroph from an abnormal lactotroph, where the normal will get stimulated with TRH, whereas an abnormal pituitary tumor secreting prolactin will not show the stimuli. The next is a dopamine. Dopamine is the center, it's a hypothalamic catecholamine. In the prolactin physiology and pathology, this is the central molecule, I would say. And this has a negative feedback. Prolactin is one of the hormones which is under a negative feedback control as against the others where there is a positive feedback control mainly. And same thing was used in the past with the metoclopramide test by giving a tablet of 10 milligram and 120 minutes prolactin. The normal pituitary will get stimulated as against the abnormal tumors will not get stimulated with metoclopramide. And certain centers still do this test whenever there is a doubt to differentiate a normal from an abnormal prolactin. Going ahead with the dopamine, as an endocrinologist, whenever a dopamine antagonist drug is used in practice, like prokinetic, which is used over the counter, or a neuroleptics, we see the prolactin going high. The question usually is asked how high the prolactin can go. So usual dictum is to say that it is up to 100 or up to 200, but there are case reports or series where the prolactin can go up to 345 as shown in this series. And we at KEM have seen prolactins as high as 700 in cases of drug-induced hyperprolactinemia. It is easy, you know the history, and if you are able to stop the drug and reassess the prolactin within days, we get an answer. When it comes to a prolactin pathology, we use D2 agonism in a form of the drug and the treatment. And this dopamine receptor on the lactotroph is linked to the PIT1 transcription factor physiology of PIT1 transcription factor and the lactotroph leads to a dopamine receptor, D2 receptor, and that is what is used as a treatment. And we have all graduated to cabergoline as a drug in this aspect. Just a small detour from the dopamine receptor before understanding the cabergoline treatment. The type of prolactinomas, microadenomas are female dominant, but when it comes to macroadenomas, when Shruti have analyzed the data at KEM, we had 100 patients of macroadenoma and it was equally distributed in the males and females. And when we go to giant tumors, it is higher in the males. So when we talk about macroadenoma, 1 to 2 centimeter tumors will be more in females. And we talk about larger tumors more than 4 centimeters, it will be more in the males. And plus, the larger tumors come with mass effect along with hypogonadism, whereas a smaller tumor, the predominant manifestation will be hypogonadism. And the mass effects can be headache or seizures, and the headaches can be classical as cluster headache, or the neuralgic form headaches on the side of the lesion can also be seen. And what we related, like the relation between T4 and TSH, similarly, we see a relation between the tumor dimension and the prolactin. There is a log linear relation is there. Now talking about the D2 agonism, the typical case of microadenoma, it's very easy to treat. And the cabergoline helps in most of the cases and more common in females when a prolactin is high. We do an MRI to rule out sinister pathology. We find out a microadenoma started on cabergoline. Now the next question, the most important or pertinent question is how long this cabergoline is to be continued. So just an example of this lady who came last week to us. What we can see is she has been following at KEM since 2004 or 5. when she was diagnosed to have high prolactin, cabergoline was started. Prolactin went down as low as less than 5. And I always remember whenever a new resident in the third year reads this article of NEGM where the cabergoline can be withdrawn, and we withdraw cabergoline, and after withdrawal we have to monitor, but you can see that the prolactin goes up after withdrawal and cabergoline has to be restarted. Recently, because of COVID, she was not following in last 1 year. She has stopped cabergoline. Again, when we monitored, the prolactin went up and it came down. So how long do we need to continue this cabergoline in this lady? It's practically till her reproductive life or till menopause, we have to continue cabergoline in this lady. So that becomes a minus point for this drug therapy. Hence, the analysis from the surgery group is coming that we can cure a microadenoma in one go, and it is a safe surgery as against your lifelong cabergoline, which may be required in some cases. An alternative could be if they are intolerant to cabergoline, the deficiency is hypogonadism. It can be replaced with estrogen and progesterone in the form of OCP. And so all these cases can be individualized as well. There is one hope that patients who get pregnant, during pregnancy, we tend to hold cabergoline, and usually these microadenomas don't grow, though exceptions are always as case reports. And post-pregnancy, they lose follow-up, they don't come back. Probably 1/5 of them have normalized their prolactin during this phase of pregnancy and lactation. So that's a hope that it may get normalized after pregnancy. Post-menopausal age, we don't treat such cases, but what is the implication of that borderline high prolactin on the health is still not known. Coming to dopamine agonism in cases of macroadenomas and giant tumors, it do work in giant tumors as well, as shown from our data, which was collated by Sri Krishna Acharya. And we have seen that the prolactin dramatically fall in most of the cases with variable doses of cabergoline, and we can manage giant prolactinoma. Here, the surgical friends will not have that one-time treatment option, because even if you debulk after surgery, they would require lifelong treatment. So surgery may not be a contender in a cases of macroprolactinoma and a giant prolactinoma, as against they can contend it for a microadenoma. So when it comes to dopamine agonist and cabergoline in the form of treatment, we understand the prolactin normalization happens, the mass effect goes down. As seen, this was one of, when I was a first year resident in 2007, this man came from Ulhasnagar with temporal lobe epilepsy and had a huge prolactin of 29,000. And with cabergoline, it actually melts away. There is no mass which is visible on the scan on follow-up. And so he had a complete morphological and a biochemical remission. There are other cases where we see reduction in the size and the reduction in the prolactin, but it doesn't normalize to a normal prolactin, or the size is still persistent. So these are partial responders. And there are 1 in 10 or 10% of the cases may grow despite prolactin. And these are truly the aggressive tumors with high MIB index, and they don't respond to cabergoline, and we have to resort to all other measures like surgery, radiotherapy, and temozolomide in such cases. So most of the times, as a rule, 80 to 90% of the times, we have response of prolactin and mass effect with cabergoline, which is a good drug. What are the predictors of response? Usually it has been believed that male prolactinomas are more resistant than the female prolactinomas, but that is because it is confounded by the size. So what we have learned from Shruti's cohort, that it is not gender dependent, it is the size dependent, because female macroadenomas are smaller in size. That's why they respond better, as against a relatively larger number of larger tumors in the male cohort. But if you compare size to size, males are doing better than females when it comes to cabergoline responsiveness or resistance taken either ways. Resistant prolactinomas, pathophysiology, the D2 short and the D2 long receptor. The D2 short receptor is lesser in the resistant ones, but it doesn't help in deciding a patient management as such, because it can be either ways because of the overlap. But whenever you see a resistant tumors, this lady who had come last time during the COVID period. The prolactin was 81. It was a microadenoma from Navi Mumbai. Tejal would remember that case, and she was not responding to prolactin, cabergoline. So we were scratching our head, what is happening in this case? And we thought, okay, if it could be a non-functioning pituitary adenoma, the prolactin should have gone down completely. And if it was a prolactin secreting tumor, there should have been some response. Rather, there was no dent in the prolactin on follow-up, and she was planning pregnancy. One of the residents thought that it could be an acromegaly, and they did a IGF-1 value, and to the surprise, it turned out to be a growth hormone co-secreting prolactinoma, and that could explain why these cases were resistant. And we have also observed in the past that ACTH co-secreting prolactinomas are usually resistant to cabergoline. Another cause of resistant prolactinoma, which is well described, is a cystic prolactinoma. As you can see in our case, we have gone up to the dose of 7 milligram in this case. Though there is a reduction in the prolactin value, we could not achieve normalization of her cycles, and prolactin still remained high. And finally, on discussion, we have subjected this patient to surgery because it was not getting responded, and she has done well after the surgery. Other concerns. So from 2005 to 2015, the main concerns, if you look at in the literature, was a cardiac valvulopathy, which have been taken care of today. And unequivocally, everyone feels that this is not a major concern. And same thing was seen in a cohort of 100 patients, which Shruti have followed with a cardiologist. And we have also seen that it is not a major concern in our cohort of patients, even on a long-term cabergoline, on a long-term therapy. But what is lately realized is the impulse control disorder has to be taken care of in this subset of patients. It is understandable that whenever for psychosis, when we use neuroleptics, it causes hyperprolactinemia. But for hyperprolactinemia, when we use D2 agonists, you are going to get some component of psychosis. And psychosis is subtle in these cases in an impulse control behavior. Hypersexuality has been usually described. We have also encountered in some of our patients, but usually it is transient. And cases where it was not transient, we have to resort to stopping cabergoline and going for surgery and radiotherapy in those cases also, and treating a prolactinoma like a non-functioning pituitary adenoma. Another thing is pathological gambling, resorting to alcohol, smoking. So what is the dictum is, when a patient says that I am doing good on cabergoline, please ask the family, is it behaving well, or he's going through these impulse control disorders on cabergoline, should be a check. If patients are on long-term cabergoline, should be considered. Other concerns like CSF rhinorrhea is there. So always we start with the smallest possible dose, and which usually works. Once in a while, we have used estazolamide, and it has helped to restrict the rhinorrhea and prevented the surgery in those cases. And in cases where the rhinorrhea has been persistent, we have to go for a repair in those cases. Rare cases of optic nerve herniation has been described, and there is always a theoretical concern of peritumoral fibrosis. In case we have to resort to surgery at a later date, that may be a concern for the surgeon later. Another physiological basis of high prolactin is estrogen is a positive stimuli, and that we clinically see in a hyperestrogenemic states like polycystic ovarian syndrome. The prolactin is borderline high in the range of 25 to 50. Patients on oral contraceptive pills also have a borderline high prolactin. This was an interesting case of FSH secreting pituitary adenoma, which had a high prolactin of more than 200. Initially, we thought it could be a NFP or a prolactinoma, but why a prolactinoma should have a ovary size of 135 cc was a concern. So 3 diagnoses were kept initially: prolactinoma, non-functioning tumor, or a FSH secreting tumor here. With this multicystic ovary, we were thinking on a line of FSH secreting tumors as well. So what looks like, it turned out to be IHC stained positive for FSH only, and it is a case of FSH secreting gonadotropinoma. And pathophysiology, it was a hyperestrogenemia, which was driving the high prolactin, which responded very well to a 0.5 milligram of prolactin. And this patient has undergone surgery and radiotherapy now, and the ovary size is behaving fine. Another thing is testosterone aromatization and estrogen excess. There are certain rare cases of prolactinoma with hypogonadism. If you start them on testosterone, you should be very careful about the rise in the prolactin, which may happen in certain subset of population. So in this case, temporarily it was shown after starting testosterone, prolactin went up. Again, exposure to testosterone, prolactin went up. So the testosterone got aromatized to estrogen, and estrogen was a positive feedback to the prolactin secreting tumor as well. And when they have added a non-aromatizable testosterone, the same surge was not seen in their case. So these are the pathophysiological mechanisms which we have seen in our cases where estrogen excess can explain the high prolactin. So now we have learned what works on the lactotropes. Now, what does this prolactin do to us is something we would like to understand. This prolactin acts on the adrenal glands, the hypothalamus, and the breast tissue. On the adrenal gland, what does the prolactin does is we can understand from the PIT1 cohort of patients. PIT1 transcription factor defects have very low prolactin, thyroid, and growth hormone values. And in these cases who have been replaced with growth hormone and thyroid hormone, they still have very low DHEAS value, and the adrenarche is absent in these cases. So the PIT1, prolactin, adrenarche, DHEAS is one link, and that is how the adrenal androgen excess with high prolactin is linked to. Similarly, when Swati have analyzed our cohort of 16 PIT1 patients, what we have observed is the girls who are having regular cycles, despite having regular cycles on thyroid and growth hormone replacement, many of them have absent pubarche in these girls. And that is one of the physiological mechanism of prolactin, which we have learned from this cohort of patients. Second action of prolactin is it acts on the hypothalamus. How does it act on the hypothalamus? So prolactin is a hormone which is made during lactation. In lactation, what we want is an ovulation. So how does prolactin do? Even before, when we knew what about the kisspeptin neurons, in 1975, it has been shown that it leads to LH hypogonadotropinism and FSH normogrowth. So FSH remain normal during lactation, and only the LH is suppressed because of the prolactin, and which we know today is via the kisspeptin pathway. Prolactin works on the kisspeptin, the LHRH, and the LH secretion goes, and which leads to anovulatory infertility in these cohort of patients. And there's a relative sparing of FSH and the estrogen. Similarly, what we look at in a male, a high prolactin will work on the kisspeptin neuron, decrease the GnRH, specifically the LHRH surges, and you will have a relative sparing of the FSH and a predominant involvement of the LH testosterone axis in this cohort of patients. So this LH-FSH discrimination, if we look at, can help us to clinically discriminate certain conditions which we routinely encounter, especially patients of polycystic ovary, PCOS patients. When they come with LH-FSH reports to you and a borderline high prolactin, sometimes we are in doubt whether it is a primary prolactin problem or a PCOS problem. So in a primary PCOS problem, LH-FSH will not be elevated as against in the PCOS, where the primary pathology is hyperestrogenemia and the LH would be elevated. Similarly, in OCP-induced cases, we will have a low LH and FSH, whereas in a non-OCP drug-induced hyperprolactinemia, the LH-FSH will behave similar to a microadenoma. When we look at a radiology of a macroadenoma and we are in doubt whether this prolactin is coming from an NFPA or prolactinoma, again LH-FSH will help us. The LH-FSH being on a lower side in a true prolactinoma, whereas NFPA, which are actually a component of gonadotropinoma, will have a borderline high LH-FSH as against prolactinoma. So these LH-FSH values can give a subtle clue when we are dealing with a diagnostic dilemma in a set of patients. So this is very useful from physiology to the diagnostic thing. Coming to the treatment option of cabergoline, in macroadenomas, we can normalize prolactin, we can reduce the size of the tumor. The next question is, can we restore eugonadal state? This was a question. And what we have realized that most of our macroprolactinoma males on follow-up were not normalizing testosterone and they were requiring testosterone replacement. So that is a state when we started looking at this. And when we looked into the literature also, that on follow-up, about 50% of the patients may have persistent hypogonadism on treatment with cabergoline across India, and one study from India as well from PGI. So what are the possible mechanism for this? So I've normalized prolactin. Despite normalizing prolactin, I am one could be a resistant prolactinoma. I have not normalized prolactin, so I don't talk about testosterone normalization. Second possibility is, despite normalizing prolactin, I am not getting a normal testosterone. Possibility we think is a gonadotrope damage, which is a structural damage due to the surgery, radiation, or tumor. So considering this into mind, we have planned this study where we have included only the patients who have achieved normoprolactinemia on cabergoline alone, so that the pathophysiology of these factors is out. When we followed this cohort of 30 patients, the eugonadism was achieved only in 1 in 4. So 25% could achieve eugonadism, and the predictors for that were the higher the prolactin, lesser the chances of achieving eugonadism, higher the tumor size, lesser the chances of achieving eugonadism. That was understandable. But what was more interesting to us was, so is it a gonadotrope damage due to the tumor? Okay, that's why they are not recovering. Then why there is a differential response in the LH and FSH? Was people who have not recovered have a LH which was low as against the LH which was normal in the other cohort, which is understandable again. But the FSH and the inhibin was equal in both cohort of patients. So the same if it is a gonadotrope damage, there cannot be a sparing of FSH, which is being produced by the same set of cells. The same gonadotropes are making LH and FSH. So we have proposed it's a chronic functional LH suppression, which has happened because of a long-standing hyperprolactinemia in these cases, and it may take years to recover, as we have seen in cases of exogenous Cushing's. A similar corollary was given in this subset of patients. What we learn and how do we apply this information, what we have generated from this cohort which got published this year in JCM, is whenever a prolactinoma we are managing, if it is a very high prolactin and a larger tumor, the chances of gonadotropin recovery is lesser. And if at all it is 1 in 4, so consider early initiation of testosterone treatment in these cases. What we have learned, the testosterone may get aromatized to estrogen, and in certain subset of patients, you may have a surge in prolactin after starting testosterone. These cases can be managed by adding aromatase inhibitor, but these are very rare cases. And when it comes to fertility options, the problem is mainly with the HCG. So we can use any of these options which are available, like GnRH, HCG, and HMG. But from the pathophysiology, what we have understood is HCG alone should be useful. And even in further milder cases, aromatase inhibitor or clomiphene can help us to achieve fertility in this subset of population. Infertility is not a rule in cases of prolactinoma. This is a man, 33-year-old, MEN1 genetics proven case with PHPT, father of one child with a prolactin of 2000. His testosterone is just borderline, lingering around at 3 and 4. Even on cabergoline treatment, we can see the testosterone has not improved well. And he has fathered a second child without any treatment specifically for the fertility in his case. Just another example of another case with galactoria and headache. With treatment with cabergoline, we can see the testosterone has not normalized. Hypogonadism was managed with testosterone treatment. And when it came to fertility, the FSH inhibin axis was okay. And with the help of HCG treatment, within a short span of time, the sperm analysis showed sperm, and he has fathered a child on HCG. So this pathophysiology is helpful, and the prolactinoma are cases of mild hypogonadism with a selective involvement of HCG axis is the learning from this case, and that LH suppression can be long-standing. I would like to thank the audience for patiently listening to me. Thank you.
Thank you, Anurag. You have done very well. And that was quite a good presentation of what all can go wrong while treating, before treatment, and other things. I would like Dr. Ganpati Bantwal to take over. You are also co-chairperson. Is he around? Dr. Ganpati, would
Yeah.
you take over?
Come, ma'am.
Thank you.
So then, thank you, ma'am. The next talk is by Dr. Ravi Shah. He is a consultant endocrinologist, Life Care Institute of Medical Science and Research, Ahmedabad. He has been the ex-assistant professor, Department of Endocrinology at KM Mumbai, consultant endocrinologist 2020 onwards. He won the gold medalist in DM endocrinology in 2019. Received the third prize in oral presentation category at the ISBMR 2020, has 17 publications. So he'll be speaking on lymphocytic hypophysitis, nuances in diagnosis and treatment. Over to Dr. Ravi.
Thank you very much, sir, for the kind introduction. I'm not able to share the slide.
Ravi, you can share now.
Okay. Hello.
Yeah, please, we can hear you.
Ravi, your slides are not yet visible.
I think he's got this is frozen.
Ravi, close the presentation, open the presentation in different window, then you can share it.
I think connectivity issues.
Ravi, you are muted also. Just speak with him.
We can see your slides now. Go ahead, you are muted.
Please unmute.
Ravi, please unmute.
Ravi, please unmute yourself.
I think his
Ravi, unmute करो ना, unmute. हाँ, slides are visible. Yeah.
Sorry for the interruption. Today I am going to talk on the topic of hypophysitis, nuances in diagnosis and management. This will be a case-based presentation where we'll be sharing the rich experience which have been gained at the Department of Endocrinology, KM Hospital, Mumbai. We all know hypophysitis is etiologically divided into primary and secondary form. The primary form is idiopathic, which is
Just see whether it's clean.
Rule out the secondary form, which to rule out underlying systemic autoimmune or granulomatous and infectious or infiltrative disorders. The pathologically hypophysitis has been subdivided into lymphocytic, granulomatous, xanthomatous, or necrotizing subforms. Radiological classification is also there, which is based on the affection of the anterior pituitary, that is termed as adenohypophysitis, where the hormonal involvement is preferential ACTH involvement, followed by thyroid and gonadotropes, and followed by growth hormone axis. The second one is the predominance of stalk and posterior pituitary involvement, that is known as infundibulous neurohypophysitis, where we can see a central diabetes insipidus. In very rare cases, there can be affection of growth and gonadotropin axis. The third one is the affection of both anterior as well as posterior pituitary function, that is termed as panhypophysitis, where clinically the presentation will be similar to adenohypophysitis, as well as there can be a presence of DI. So the diagnostic clues are from the history point of view. For the lymphocytic hypophysitis, it is the peri or postpartum onset of symptoms. In the case of secondary hypophysitis, there may be associated symptoms of underlying autoimmune, inflammatory, and infectious disorders. In case of newly described the drug-induced hypophysitis cases, there may be a pertaining history of exposure to immune checkpoint inhibitors or interferon alpha. For us, the endocrinologists, the main thing is the biochemical clue that we should not forget. That's the form. If we see hormonal deficits which are out of proportion to the size of cellular lesion, then we should suspect hypophysitis. And in these cases where there is adenohypophysitis, there will be predominant involvement of HPA axis, which is followed by gonadotropin and thyrotrope axis, and the least affection will be in the growth axis. But in the most cases, the diagnosis is based on the characteristic MRI findings with a Gutenberg score of 0 or less. So these are the typical imaging features in a case of hypophysitis, where most of the cases with adenohypophysitis will present with a definite cellular mass, which has a homogeneous contrast enhancement. In a case of infundibulous neurohypophysitis, there will be a predominant involvement of stalk thickening as well as loss of posterior pituitary hyperintensity. Supracellular extension is also seen in majority of cases, and in half of the cases there can be a characteristic T2 dark sign, that is a T2 hypointensity on the MRI, which suggests chronicity of the inflammation. In some cases, there may be extension in terms of figure of 8 appearance, and in some cases it can be a paracellular extension. Cystic changes are also seen in some cases, like drug-induced hypophysitis and granulomatous hypophysitis cases. In some cases, the inflammation leads to hypervascularity of the surrounding dura, that leads to a dural tail sign, dural hyperintensity. The Gutenberg score is a clinico-radiological score that leads to a non-invasive diagnosis of hypophysitis. That is, the parameters are based on the clinical history as well as the MRI features, and a score of 0 or less will lead us to diagnosis of hypophysitis. A score in 1 or more will lead to diagnosis of adenoma, and in a smaller series, the sensitivity and specificity of 97 and 99% was described by Gutenberg. Coming to the natural history of hypophysitis, most of the patients will present with a cellular mass and in the stage of acute inflammation, and which will over the months time, with or without any treatment, will regress with a corresponding regress in the clinical mass effects. Some cases there can be a clinical evidence relapse with cellular inflammation going on again, and most of the cases, if we don't intervene, will turn out to be a partial or complete empty cell on the follow-up of years. So coming to the management options, The goals of treatments are threefold. First is the resolution of acute mass effects. The second important thing is the replacement of deficient hormones. And on the long run, the most important goal is the recovery of lost pituitary function. So the conventional management options that are transsphenoidal surgery and observation that leads to poor recovery of anterior pituitary functions. And in the case of TSS, there can be a new onset of pituitary deficit in about 45% of cases. So in a retrospective study in 2014, we have published our own experience in pituitary, where we have shown that 33% cases there can be complete or partial recovery of anterior pituitary function with watchful observation alone. But this, as we know, it's a suboptimal recovery. So then after we switched over to third mode of treatment that we have exemplified in these following two cases. A young female presented with acute onset history of headache and vomiting, and there was diplopia and evident right six nerve palsy. The MRI was done that identified characteristic features of adenohypophysitis, and biochemically there was affection of HP axis with hyperprolactinemia. So after ruling out secondary causes, the patient was treated as for the other neuroimmune conditions, that is IV MPS pulse therapy, 1 gram for 3 days, followed by oral steroids. And over 1 week, there was resolution of clinical mass effects, and over the months, there was resolution of the radiological features of hypophysitis. And the most important thing, there was recovery of HPA axis on the follow-up. Similarly, in the second case, a 39-year-old female presents with amenorrhea and headache, and there was acute onset right third nerve palsy. Again, the imaging features suggested evidence of adenohypophysitis with the affection of cortisol as well as the gonadotropin axis with hyperprolactinemia. So, similarly, after ruling out the secondary causes, the patient was treated with pulse steroid therapy, and in 1 week there was partial resolution of third nerve palsy, which resolved completely over the follow-up after the oral steroids, and also there was resolution of the pituitary mass with recovery of cortisol axis, but the gonadotropin axis did not recover. So this also in a smaller series we have published in the same article, that is out of the 4 cases, 3 cases had a complete and 1 case had a partial recovery of anterior pituitary function with a steroid pulse therapy. So this became a standard of care in our department after that these patients with primary hypophysitis are being treated with a standardized 3 days per 1 gram methyl prednisolone pulse therapy, that is followed by 1 milligram per kg oral prednisolone dose for 4 weeks, and followed by a 5 to 6 weeks oral steroid taper. So this experience has extended now to 18 patients, and fortunately we have a control arm in the form of observation for the previous patient. And fortunately, this baseline parameters of these both groups matched. So the comparative arm was there for the steroid group, and radiologically also this both group matched, except for the higher pituitary height in the glucocorticoid arm. That suggests that over the years we have graduated to earlier suspicion and diagnosis of these cases in the phase of acute inflammation. So when we compared the outcome data for this 2 groups, we could see that there was a double. When we compared the overall recovery of anterior pituitary function, it was almost double than the observation group. And when we compared the complete recovery arm, it was almost tenfold. So there was tenfold higher recovery, higher complete recovery chances in the case of patients who are treated with glucocorticoid pulse therapy with primary hypophysitis. And this trend persisted for the individual hypothalamo-pituitary axis, but we could not see a recovery of DI in any of the involved patients. Again, the radiological progression to empty-sella was also halted with this pulse glucocorticoid therapy. And the most important thing, there were fewer recurrences than the other published literature, and there was no major glucocorticoid related adverse effect because the overall duration of the glucocorticoid therapy was smaller, that's the 10 weeks. So these are the published literature where the majority of the studies where the steroid was used in the management of primary hypophysitis have been dedicated. And first one is that by Christoph in 1999. It was a prospective study, used the pulse steroid therapy, but the dose was 120 milligram. It was a non-randomized study. There was no control group, and they showed a 50% partial recovery rate without any recurrence with steroid therapy. Again, there were two studies in 2017. Both were retrospective, and treated the patients were treated with oral steroids for a longer duration of time, but showing a suboptimal recovery and a higher recurrence rate. Only one prospective study afterwards was published that was with oral steroids. Again, there was no matched control group, and the duration of treatment was higher. It was almost 13 months. And so there was no recurrence, but the recovery was seen in 70% cases only. So this is our present study data, which is again a retrospective study. The patients have been picked up earlier, treated with a homogeneous steroid regimen. The overall treatment duration is shorter, resulting in a fewer adverse effects. We have a matched control group that can show us the natural history of disease if left untreated, and the treatment efficacy is highest with an acceptable recurrence rate. We also try to identify the predictive factors for complete recovery of anterior pituitary axis. And when we compare the data, we identified that those patients who were diagnosed earlier in the phase of acute inflammation and treated with pulse steroid, they had complete recovery of anterior pituitary function as compared to those who presented or diagnosed late and treated late with pulse therapy. So the strengths of our data, it's based on standardized protocol of treatment using a pulse glucocorticoid therapy, and early non-invasive diagnosis and treatment can lead to a complete recovery of anterior pituitary axis. This was consistent with earlier observation by Christoph et al. In 1999. A role of DI in anterior pituitary axis recovery remains debated, with one study saying it's an adverse prognostic factor, a second study saying it's a good prognostic factor. But in our study, we could not identify any predictive role of DI, but actually in our study, the number of patients having DI were quite few. So up to this data, we say that primary hypophysitis patients should be treated with a pulse glucocorticoid therapy to improve the clinical, hormonal, as well as radiological outcome. Now, does this benefits extend to other cases also? So this is exemplified in the next case, where a 22-year-old female presented with a history of 2 weeks history of polyuria, polydipsia, and a polychronial headache. The hormonal parameters showing hyperprolactinemia as well as central diabetes insipidus, and MRI findings suggestive of panhypophysitis. For looking for secondary causes of hypophysitis, we found raised IgG4 level, and to rule out any underlying systemic IgG4 disorder, FDG PET was done that showed no systemic uptake. So the patient was treated with a similar pulse steroid therapy, and there was clinical, biochemical, as well as radiological recovery. And now the patient is put on surveillance for possible recurrence. So this is a case of primary IgG4 hypophysitis. These patients also, as the pathophysiology is similar to lymphocytic hypophysitis with plasmoid cell infiltration into the cell, they respond well to the pulse steroid therapy. Now, we know all the cases are not so fortunate. A similar case, a 47-year-old female with episodes of headache, cranial nerve palsy, and progressive diminution of vision presented to us, and had a temporary response to glucocorticoid and had 3 clinically evident relapses with glucocorticoids. And on follow-up, she became panhypopituitary. She developed panhypopituitarism. So the MRI was done that showed the inflammation of sella to the surrounding region of hypothalamus, and this patient was worked up for the underlying causes of secondary hypophysitis that turned out to be negative. So the diagnosis of autoimmune hypophysitis with hypothalamitis was made. As the patient was refractory to steroid therapy, she was started on azathioprine. So in such recurrent and refractory cases, the most obvious treatment will again remain the repeat course of pulse glucocorticoid therapy, and we have seen in 2 cases that it is effective and well tolerated. But in such a case where it is persistent or refractory to treatment, then we should try surgery. or other immunosuppressants like azathioprine, rituximab, mycophenolate mofetil, methotrexate, and cyclosporine. They all have been described with one or two case reports in the literature and having good response to therapy. And now again coming to a newer etiology of hypophysitis, there's a 56-year-old female with adenocarcinoma of lung receiving chemo and radiotherapy, but still having persistent disease. So started on a newer therapy, that's immunotherapy, durvalumab. So that's the immune checkpoint inhibitor, PD-L1 inhibitor. The patient had received three cycles of immunotherapy and then developed fatigue and weakness. So the treating oncologist advised for the pituitary function profile and that identified primary hypothyroidism with hyperprolactinemia with central hypocortisolism. So an MRI was done that turned out to be normal, and this patient was diagnosed to have immune checkpoint inhibitor induced hypophysitis with primary hypothyroidism. So there are two groups of immune checkpoint inhibitors commonly used, that are CTL4 inhibitors and PD1 and PD-L1 inhibitors. The incidence of hypophysitis is higher and earlier with CTL4 inhibitor as compared to the PD1, PD-L1 inhibitors where it is lower and later. Because the CTL4 is expressed on the anterior pituitary cells, the incidence of hypophysitis is more. And similarly, the affection of anterior pituitary axis as well as the MRI characteristics are more like a primary hypophysitis in CTL4 inhibitors, whereas in PD1 or PD-L1 inhibitors, it is predominantly isolated ACTH deficiency with normal MRI and a permanent ACTH HP axis damage. Other endocrinopathies like thyroid disorders are seen in higher numbers with PD1, PD-L1 inhibitors, and there can be some cases of type 1 diabetes mellitus. So, as these cases they have underlying malignancy, ruling out a pituitary metastasis is essential before we go for a diagnosis of hypophysitis. So, a size of more than 2 centimeters or a mass with heterogeneous enhancement with cavernous extension suggests a diagnosis of metastasis as opposed to hypophysitis in this group of patients. Clinically, those patients who are started on immune checkpoint inhibitors, they should have a baseline as well as 8 and 16 weeks follow-up of anterior pituitary axis. And if any of the axis is found abnormal, there should be an imaging confirmation. As the underlying pathophysiology is different from the primary hypophysitis, here it is antibody and complement mediated direct anterior pituitary cell lysis rather than any lymphocyte infiltration. The treatment is different. So here this routine cases should be managed with a replacement dose of steroid, and pulse steroid is only indicated where there is evident mass effect on MRI or clinic. Now the ruling out the secondary causes of hypophysitis is very important before we begin this pulse steroid therapy. This is exemplified in the next case where a 27-year-old female presents with amenorrhea and a goiter. And when she was referred to us, we identified she had a history suggestive of diabetes insipidus and a cranial headache. So the anterior pituitary hormone function was done that identified affection of growth, gonadotropin as well as HPA axis with hyperprolactinemia, and the central DI was confirmed with water deprivation test. So this patient was basically a case of panhypopituitarism and goiter. And looking at our rich experience in diagnosing hypophysitis cases, we thought that it will be a case of lymphocytic hypophysitis with associated Hashimoto's thyroiditis. But the MRI was done that showed us hypophysitis with the extension of inflammation to the hypothalamus. And we had done the biochemical evaluation for ruling out underlying causes of systemic disease that turned out to be negative. But as we stick to our protocol, HRCT was done and that identified multiple cystic as well as the nodular lesion in bilateral mid and upper zones of lung. And FDG PET CT showed uptake in the thyroid as well as surrounding some lymph nodes. So FNA from thyroid was advised, and that turned out to be Langerhans cell histiocytosis. So this patient was treated with chemotherapy and not pulse corticosteroid. So to conclude, hypophysitis is a rare diagnosis that requires high index of clinical and radiological suspicion. Lymphocytic hypophysitis is the most common subtype that is characterized by classical radiological features. In most cases, it will be homogeneous contrast enhancement in an enlarged pituitary. And in cases of INH or panhypophysitis, there will be thickened stalk as well as loss of posterior pituitary bright spot. Early recognition and treatment of these cases with high dose pulse glucocorticoids can lead to better clinical, hormonal, as well as imaging recovery with fewer recurrences and adverse drug effects. Ruling out secondary causes of hypophysitis is of utmost importance before we give pulse steroid therapy. And refractory cases can be treated with other immunosuppression or surgery. Hypothalamitis can be seen as an upward extension of this pituitary inflammation, and it requires evaluation and treatment as for hypophysitis cases. IgG4 hypophysitis is a new entity that requires evaluation for underlying systemic disease, and a prompt treatment with glucocorticoid will result in a good outcome. Whereas ICI-induced hypophysitis should be recognized and treated with replacement dose of steroids in cancer patients who are treated with this immune checkpoint inhibitor. So with this, I end my talk and will invite any questions regarding hypophysitis.
Ravi, I think we'll
Yes,
go to the. We have one more session, I think. No?
Yeah. Ravi, can you stop sharing?
One topic.
yes.
Yeah, so we'll go to the last this session. So that will be dealt by Dr. Virendra Patil, and he'll be speaking hypo role of genetics and gonadotropins. So Dr. Virendra Patil is associate professor at KM Hospital, Mumbai. He has an total clinical and academic experience of 6 years, has more than 21 in peer-reviewed journals. To Dr. Patil.
Yeah. Thank you, sir. I'll be discussing the genetics of hypogonadotropic hypogonadism and the role of gonadotropins in the same. So to start with the history of genetics in hypogonadotropic hypogonadism, this was a paper published in 1944. And by this time, people used to know that color blindness is an X-linked trait. So in this particular family, they could there was a co-segregation of color blindness with the hypogonadism. So this was the first presentation of hypogonadotropic hypogonadism, and it was proposed that it is a X-linked disorder. But as time passed, after almost 10 years, there were patients, female patients, familial cases with the affected females were described, ruling out just isolated X-linked inheritance. And as the time passed, they also described the families with autosomal dominant inheritance with incomplete expressivity. So some members of the family will just have hyposmia or cleft lip or cleft palate, but they would be fertile, and the kids will be affected hypogonadism. So it can be a autosomal dominant inheritance with incomplete expressivity. Furthermore, in next few decades, different non-reproductive phenotypes were described with the congenital hypogonadotropic hypogonadism, and they were unilateral renal aplasia associated with CAL1 gene, cerebral ataxia in patients with Gordon-Holmes and Boucher-Neuhauser, ichthyosis, bimanual synkinesis, in some patients retinitis pigmentosa. So for the discovery of the genes in patients with this particular disease, the most you can think of the GNRH1 can be the most possible genetic defect in such patients, and that is the reason initially the scientists studied this GNRH1 gene in such patients. So the Sanger sequencing was discovered around 1977-78, and there was a HPG mouse, which was a naturally occurring mouse in which there was a GNRH1 gene deletion. So by this time, people knew that there is GNRH1 gene is there, and they knew how to sequence it. So the first gene to be sequenced was the GNRH1 gene in 1989. They studied a fairly large number of patients, but they couldn't find anything in such patients. So almost for the next 20 years, different groups studied different bigger number of CHH patients, but they couldn't find any defect in the GNRH1 gene. Finally, in 2009, two different groups, one was by James Boligan, another was Chan. They published their first reports of GNRH1. So it was like a finding a needle in haystack. So even if it is the most probable gene theoretically, the GnRH1 gene defects are fairly rare in patients with CHH. So the first gene discovery in patients with CHH was a Calvin gene. So GnRH1 they could sequence it, but they couldn't find in 1989. So in 1990, initially they could find out that some patients with some patients with hyposmic hypogonadism, that is Kalman syndrome, they had associated ichthyosis, which was due to steroid sulfatase deficiency. And this particular gene, these particular patients were having a deletion in this particular part of the chromosome, that is XP22.3. So by this point of time, scientists knew that this gene was located in this particular area. And after just 2 years, this David Big group, they described that the Calvin gene deletion is the causal gene for the Calvin syndrome patients. So this is the first genetic description in patients with Calvin syndrome. So when the people started studying the Calvin gene, initially they thought that it will be contributing to large number of patients, but it was just contributing to just 4 to 5% of the patients with IHH. So still there were n number of genes to be discovered. And to further this, in 1997, after 5 years of Calvin gene description, this Nicolaidou group, they published their first report of GnRH1 mutation. So the difference between these patients and Calvin was these patients were normosmic and the inheritance pattern was autosomal recessive. And the most important thing was the variable phenotype. So some patients were having testicular volume of 10 to 12 ml, and some patients were having just testicular volume of 2 to 3 ml. So there was a difference in the reproductive phenotype in such patients. And even with this this gene discovery, the contribution of this gene was just 3% to the genetic etiology of CHH patients. And then subsequently, many genes were discovered, like this FGFR1 gene in 2003, which was associated with dental agenesis, bimanual synkinesis, cleft lip or palate. And this was contributed to more number of patients. So FGFR1 contributes to almost 10% of the patients in any hypo cohort. So afterwards, multiple genes were described in a small number of patients. And by 2020 now, we know that more than 36 genes contribute to the genetic etiology of congenital hypogonadotropic hypogonadism. So it is one of the most genetically heterogeneous disorder. Apart from being a genetically heterogeneous disorder, sometimes some patients can harbor 2 or more variants in 2 or more genes, and this is defined as oligogenicity. So oligogenicity is known in previously it was known in retinitis pigmentosa or Bardet-Biedl syndrome, but with this discovery in 2010, even CHH patients, they can harbor 2 or more variants in 2 or different genes, and the number can be up to 2 to 5%. And this complicates the genetic inheritance. When you know that patient is harboring 2 different genes, so it will be a little difficult to predict the inheritance pattern in the next generation. So it has got implication in the genetic counseling. To learn these different genes can affect different pathways. So we all know that GnRH1 neuron precursors, they arise in the olfactory placoid, and they have to migrate along with the olfactory axons to the olfactory bulb and then to the hypothalamus. So there are different genetic regulators for this migration, as well as once they are migrated to develop these GnRH neurons, there are different genes implicated. So for these genes, that is Calvin, FGFR1, FGF8, prokinetin, so these genes are responsible for development and migration of the GnRH1 neurons, and the other genes are there to just for the development in the hypothalamus. So if these genes are involved, patients will not have hyposmia, but if these genes are involved, patient can harbor both hyposmia as well as hypogonadism. And so these different genetics genes are divided as per their role in neuromigration, a role in the development, as well as role in the GnRH, the gonadotropin secretion. And the clinical clues for these is you can have the clinical clue of sense of smell, as well as clinical clue of mode of inheritance. So there are all kinds of modes of inheritance are possible in patients with CHH. So it is genetically heterogeneous, as well as all possible modes of inheritance are present in CHH patients. So the Calvin gene, we know that it is an XLR gene. In such families, 1 or 2 male members will be affected, and the On the maternal side, the maternal cousins will also be affected. So it is a classical example of XLR inheritance. We all know that CAL1 gene is XLR. Apart from CAL1, DAX1 can be another gene which can be X-linked and which can cause hypogonadism along with adrenal insufficiency. Then comes the middle pathway genes, that is FGFR and prokineticin genes. These genes can cause autosomal dominant inheritance. So there is a vertical transmission. So the father had just hyposmia, but he was fertile and he could father almost 5 kids. And in these children, some of the siblings were having just isolated hyposmia, and some of them were having isolated hypogonadism. And one brother was having both hyposmia as well as hypogonadism. So it is a classical example of autosomal dominant inheritance, but with incomplete penetration. So father had just hyposmia, but he was fertile. Another mode of inheritance, which is also possible, is AR. So in this particular inheritance, both brothers and sisters will be affected in the same generation. Along with that, if there is a presence of consanguinity, it will add upon to the, it will give additional weightage to this AR pattern of inheritance. So apart from this inheritance, there are different non-reproductive phenotypes in such CHH patients. So some patients can have renal agenesis, which is described in CAL1 patients, and synkinesis, which is described in CAL1 as well as FGFR1 patients. Musculoskeletal problems and with midline defects like dental agenesis, polydactyly, campodactyly, that is fixed flexion deformities of the fingers, or clinodactyly, these all have been described along with cleft palate in patients with FGFR1 or FGFR8 mutations. And hearing defect is also described in such patients, in patients with CHD7 as well as SOX10. So whenever you get a patient with Kalman syndrome, you need to look for ultrasound KUB to look for the renal agenesis. You need to get for the Puritan audiometry to look for any sensory neural hearing deafness. As well, you need to get an MRI to look for any olfactory bulb agenesis, as well as to rule out any masses in the cellular area. But having said this, having described this, all these non-reproductive phenotypes, many of the patients are there who will not have any kind of non-reproductive phenotype. And in most of these patients, they will have nomosmia. So this non-reproductive phenotype, as well as just the mode of inheritance, is not going to tell you which gene is responsible for this patient. And to study the genetics, our department started doing the genetic study from 2008 onwards. And this is initial data of Sanger sequencing of 5 genes in 135 patients, published in Clinical Endocrine in 2015. So in these 135 patients, only 5 genes were studied, that is CAL1, FGFR1, FGF8, GnRHR, and KIS1R. So in 5 genes, in these 135 patients, the RSV detection rate was 15.5%. So please note this term RSV. So this is a rare sequence variation detection rate. Nowadays, no journal will accept this particular term. Now the terminology has changed. So in this particular paper of ours, the detection rate was 15% and oligogenicity was 1.5%. And we had few novel findings in this particular study. When we compared this particular Sanger sequencing data with the world literature, the CAL1 and FGFR1 percentage of patients in our cohort was comparable to the world literature, but the patients with GnRHR was significantly more in our patients compared to the world literature. So we had more of GnRHR patients. And amongst these GnRHR patients, there was one particular variant, that is C279Y. It was recurrent in 4 of our patients. And when we look back into the literature, there was one patient described in the literature, but the patient was again from the Asian ancestry. It was a Pakistani patient. So we hypothesized a possible founder mutation effect in this for this particular variant in our paper. So after this Sanger sequencing data, we studied the CHH patients with next generation sequencing. So before that, these CHH patients, sometimes they can have a syndromic hypogonadotropic hypogonadism, and these are different syndromes in which patients can have hypogonadotropic hypogonadism along with some syndromic manifestation. And to describe few, this is our experience with our syndromic hypo patients. So this is a patient of with hypogonadism, which is central in origin. He also had cerebral ataxia with cerebral atrophy on the MRI with mental retardation. So this is a patient with Gordon-Holmes syndrome. Another very rare patient who had CPHD. She was having ectopic bright spot with this triad, APH with ectopic bright spot with interrupted stalk. In addition to this particular finding, she also had hyposmia, the anosmia, which was proven with UPSIT as well as MRI showing olfactory bulb aplasia. So there is a genetic overlap in patients with CPHD as well as hypo, and it is very well described in the literature, though it is very rare. Coming to the next syndromic hypoego, there is another syndrome that is called as Baucher-Neuhauser syndrome. In such patients will have hypogonadism with cerebral atrophy, which leads to ataxia, with retinitis pigmentosa, which can lead to blindness. So to move ahead with the world literature, because this CHH is the more than 35 genes, more than 39 genes are implicated in patients with CHH. It is almost impossible to sequence each genes with using Sanger sequencing. So we moved ahead with the patient with the targeted next generation sequencing in patients with CHH. And for this, we used a clinical exome gene panel, which consisted of 4,800 genes. And amongst these 4,800 genes, we particularly look for the 29 known genes which are implicated in hypogonadism. And we could identify these 43 patients with these different genetic variants. And to look for any predictor of genetic positivity, so we had 43 patients who harbored pathogenic or likely pathogenic variant in CHH genes versus 107 patients who were mutation negative. And to look for any prediction of genetic positivity, we studied different factors. So Kalman or normosmic or cryptorchidism or male-female was not predictive, but the severity of hypogonadism. So the severity of hypogonadism is based on the reproductive phenotype. So any patient whose testicular volume is 4 ml or more is considered as a partial phenotype in males, and any female who has got any breast growth, that is B2 onwards, is considered as partial. So with testicular volume of less than 4 ml or no breast growth is considered as a severe patient with CHH. So higher is the severity of the reproductive phenotype, more is the genetic yield. So severe patients are they are likely to have a mutation positivity compared to the mutation negative patients who will have lesser number of severe patients. And as we all know, the familial cases will have a more genetic yield compared to the non-familial cases. When we sub-studied the normosmic cohort of 72 patients, again, similar finding was found to us. The patients with severe phenotype had a more molecular percentage of more molecular diagnosis. That is almost 45% patient had some or the other genetic yield in such patients compared to the partial phenotype patients only, in whom only 20% of the patients harbored genetic etiology. So this term is also very important, the molecular diagnosis. So if you sequence, if you use next generation sequencing in patients with CHH, you are going to find a large number of variants in such patients. But molecular diagnosis can be reached only in the presence of pathogenic or likely pathogenic variants in the known CHH genes when present in the zygosity matching their inheritance pattern. For example, we all know that GNRHR gene is inherited in autosomal recessive pattern. But if you find a GNRHR gene in a heterozygous state in a patient with congenital hypo, even if that mutation is pathogenic, because it is present in the heterozygous state, which cannot explain the genetic causality, which you cannot consider that as a molecular diagnosis in that particular patient. So this molecular diagnosis is very important. And this is very clear after 2015 guidelines by American College of Medical Genetics. So it is like a Bethesda testing for our thyroid FNSE. We should always consider pathogenic and likely pathogenic variants only, as opposed to benign or likely benign variants. There are some patients in whom some variants are there, which are classified as variants of unknown significance. In such patients, you can use the segregation analysis or functional studies are required to definitively say that whether they are causal or not. For molecular diagnosis, we always use pathogenic or likely pathogenic genetic variants only. So to review the world literature, so these are the 8 studies till now before our study, which used next generation sequencing in patients with CHH. And every study had a very significant number of population, at least 50 or more, except 1 or 2 studies. And they also studied large number of genes, but the causal number of genes which are known known to be implicated in CHH patients were 40 to 60. And if you see that molecular diagnosis could be reached in just 30 to 40% of the patients. And when you see if the number of patients, if the study included more than 100 patients with CHH, for example, in Casatella or Zhu et al. Or in Amato, the molecular diagnostic yield was just 20 to 30% only. For example, 22% in Casatella et al., 20% in this Chinese study Zhu et al., and 26% in this Brazilian cohort. So this clearly shows that still there is long way to go in patients with to unfold the genetics of the CHH patients. Almost 50 to say in 60 to 70% of the patients we don't know the genetic etiology, and probably whole exome sequencing is going to help. And from a study, we could add something to the literature. For example, GnRH1, which is very, very rarely described in patients with CHH. So these are the 8 patients till now described in the world literature having GnRH1 gene with only 5 variants described till now. And in our study, we could find 2 patients with 2 novel GnRH1 variants, which will be the addition to the literature. Apart from this GnRH1 novel gene, 2 genes, we could also identify this particular variant of GnRHR, that is PT32A, which was recurring in 4 patients in our cohort. And this particular variant is not reported in any other ancestry apart from the Asian ancestry. So we hypothesize that this another variant having a possible founder mutation in addition to this C279Y, which was described in the previous study of ours. So for the genetics of CHS, the genetics of CHS is very heterogeneous, and all kinds of mode of inheritance are possible, and the oligogenicity makes it more complex. And there can be patients with variable inheritance. There can be patients with just hyposmia or cleft lip palate who can be fertile, but the offsprings of their these patients can have a complete hypogonadism. The non-reproductive features may not help you always, except very, very specific, like renal agenesis, which is mentioned in Calvin gene, or retinitis pigmentosa or ataxia, which is mentioned with the PLPNA gene. And the genetic yield was found to be 37% in our patients with using the NGS technology, and almost 4% had oligogenicity. GnRHR gene was more common in our patients, and this P279Y and T32A had a founder effect. So we discussed the genetics of hypo now, which is very heterogeneous. Now coming to the treatment, what is new in the treatment of patients with CHH? So the gonadotropin treatment is new in such patients, and it's not new, but it should be revisited. So we all know that when the HPG axis gets activated, it will have the implication on pubertal induction with the achievement of secondary sexual characters, as well as the fertility induction, that is achievement of spermatogenesis. So both are needed to call it as a complete pubertal induction. So secondary sexual characters can be easily achieved with the exogenous testosterone replacement, but we don't just want the secondary sexual characters, we also want fertility for our patients. And this 2015 consensus statement of CHH clearly mentions that gonadotropins or pulsatile GnRH can be used as a mode of pubertal induction in such patients. And they use these 2 particular words, HCG alone or combined. We will be discussing this afterwards. And when you use gonadotropin based treatment, they have got very good physical and psychological outcomes. And this was proven in a RCT in a small Japanese cohort. So this gonadotropin based treatment is not new. It was already known in the literature, and this 1979 article clearly mentions the different protocols for gonadotropin based treatment in patients with hypogonadotropic hypogonadism. So in our department, we started this pubertal induction from 2010 onwards, and gradually the number of patients were increased. And in initial few patients, we always started these patients with the combined gonadotropin. So we used to start these patients with HCG with a small dose 5,000 to 500 to 1,000 twice a week subcutaneous, along with HMG. So we used to start the combined gonadotropins at once only, and gradually every 3 to 6 monthly, with the monitoring of these parameters, we used to increase the dose, and the maximum dose used to be 2,000 thrice a week in most of the patients, and HMG will be maximum dose will be 150 thrice a week in such patients. And the endpoint of our pubertal induction used to be adequate virilization along with good testicular volume buildup, and which is stable even with continued gonadotropin treatment. And once patient used to achieve this pubertal induction, we used to shift patient on androgen or continue SCG monotherapy after the discussion with the patient. And these are few cases in which in whom we use gonadotropin based treatment for pubertal induction as well as fertility with very gratifying responses. So this is a 15-year-old boy who presented with delayed puberty, but because he had a complete absence of smell, we were confident enough that it is a patient with Calvin syndrome and we should start treatment. And subsequently, he turned out to be a patient with carrying Calvin mutation as well, a pathogenic mutation. So in this patient, we started with a small dose of SCG and HMG, and gradually we built up the SCG and HMG dose with a maximum of 2,150 units thrice a week. And you can see that from the baseline testicular volume of 2 ml over a period of almost 4 years now, his testicular volume is 15. Because his testicular volume continued to grow, we continued the gonadotropin based treatment. And you can see that he has reached almost a normal testicular volume with this continued gonadotropin based treatment almost for 4 years. And with a very gratified response in the both in achievement of testicular volume as well as achievement of the secondary sexual characters. So gonadotropin can be very well successfully used for pubertal induction. So can we use this gonadotropin treatment for other patients? So this is a case in whom I would like to highlight that this gonadotropin based treatment can avoid surgeries in patients with cryptorchidism and with in CHH patients. So this is a 10-year-old boy who presented to us with a small size phallus along with bilateral cryptorchidism. On detailed family history, he had maternal cousins with hyposmia. So we are pretty confident that this patient is having some familial Kalman syndrome, and the MRI also revealed absent olfactory bulbs. And you can see that he is having hypoplastic, very poorly formed scrotum with a small phallus. Because we were fairly confident that this patient is having CHH and he was not had mini puberty, which will help in most of the patients with cryptorchidism for the descent of the testes. So we tried to mimic the mini puberty in this patient. We started this patient on HMG 150 thrice a week for almost 4 months, and after that we added HCG to this HMG, and after 5 to 6 months, you can see that his scrotum developed well. There was descent of these inguinal gonads, and they remained in the scrotum only. So we could successfully achieve the descent of the undescended testes, as well as increase in testicular volume and enlargement of the SPL size. So in this particular patients, we avoided surgery for the cryptorchidism, and we successfully used gonadotropins. And after this patient, we use this particular gonadotropin based treatment for almost 5 different cases, 5 another patients with CHH only with successful response. So having discussed the benefit of gonadotropin based treatment in patients for pubertal induction as well as cryptorchidism in CHH patients, this is another patient who presented to us very late at 25 years old. And by that time he had already married, and he had come to us that he's not able to father a kid, and he has got very poor secondary sexual character. So you can see that he was having a very severe phenotype with testicular volume of just 1 to 2 ml and very low level of gonadotropins as well as testosterone. In this patient also, we started combined gonadotropin treatment, that is HCG as well as HMG. And after almost 17 months of treatment, 27 months of treatment, he had got a very good spermatogenic response, that is 32 millions per ml. And now, after almost 3 years of treatment, he has fathered a baby. And on genetic analysis, he is harboring very rare biallelic GnRH1 variant, missense variant in GnRH1 gene. So this is another example of successful gonadotropin treatment for fertility. So in this patient, we can call it as a pubertal as well as fertility induction, because he was not exposed to testosterone previously. He was directly started on combined gonadotropins with a gratifying response. So not every patient will respond wonderfully like these patients. So this is another example of 24 years old male with a severe phenotype with a small testicular volume with absent secondary sexual characters. And his younger brother was also affected. And so this is a case of familial severe normosmic hypogonadism. So in this patient, we started with combined gonadotropin treatment, And gradually with 3 to 6 monthly, we increased the dose of SCG as well as HMG. But even after almost 40 months of treatment, there was no sperm. So he was having azoospermia, and the fructose was positive. So ruling out the obstructive cause of azoospermia. But if you look at the testosterone, he had very good testosterone response. So this is a patient who had responded to gonadotropin-based treatment only in terms of achievement of the testosterone, but there was azoospermia. So we decided that we label this patient as a failure to the gonadotropin response in terms of spermatogenesis, and we shifted to the injection testosterone. So can we identify such patients and allow patient for to go for another fertility management like sperm donation or ICSI or TACI? So we need to know predictors of gonadotropin-based treatment and predictors of response in such patients. So this is a JCM article published in 1988, which has touched to this predictors of fertility in such patients when we use gonadotropin treatments. And you can see that the testicular volume. So higher is the testicular volume, better is the response as a fertility. And as the number of cycles of gonadotropin response, gonadotropins goes up, the response gets better. But if you look at the prior androgen use, if the patient is already exposed to the androgen, so in most of such patients with CHH, the traditionally everybody used to start patient on testosterone replacement therapy. But in such patients, this prior androgen use can be a negative predictor factor for fertility, which eventually patient is going to need. So we should be aware of this particular entity, that if the prior androgen use can have implications on future fertility, negative impact on the fertility in such patients. And why is that? We just discussed that thing only. So we have to understand this negative impact of the testosterone prior androgen use on fertility. We need to know the physiology of androgens and FSH. So whenever a patient with CHS is given FSH, there will be increased number of seminiferous. There will be lengthening of the seminiferous tubules as well as the increase in number of Sertoli cells. But once the patients are exposed to the testosterone, whether it is exogenous or whether it is endogenous, after the patient started on SCG, there will be palisading of Sertoli cells, and there will be differentiation as well as maturation of the Sertoli cells. So Sertoli cells are not going to further replicate and grow in size. Similarly, the seminiferous tubules, they will differentiate and they will stop growing further once they are exposed to the testosterone. And again, this is proven with the biochemistry. As we all know that this AMH hormone is produced by the immature Sertoli cells. If you give just FSH to these patients, AMH is going to go up because the number of Sertoli cells are increasing. But once these patients are exposed to the testosterone, this AMH is going to go down, because once the Sertoli cells mature, the mature Sertoli cells, they don't produce AMH. So this testosterone exposure is going to produce the maturation of the Sertoli cells. And this is so why these Sertoli cells are protected in mini puberty? Because in mini puberty, these patients produce the testosterone level as good as the adult testosterone levels. But in mini puberty, the Sertoli cells, they don't express enough androgen receptors. That is the reason they are not adversely affected. But as we grow in age, the androgen receptors, the number of androgen receptors, they grow up in the Sertoli cells, and they can have negative impact if these patients with CHS, if they are given just testosterone before they are given gonadotropins. And to study this hypothesis only, this particular group by Revio et al., they had studied just 3 patients, and this 3-patient series was published in 1997 in Lancet. So what they did, they gave just FSH to these patients, and you can see that just by giving FSH, the inhibin B, which is again secreted by Sertoli cells, it goes up. So Sertoli cell number can be increased with FSH pre-treatment. And to further this, they studied, they did a RCT, small RCT, including just 13 patients. So what they did, they studied patients with CHH either on recombinant FSH followed by GnRH versus only pulsatile GnRH. So those patients who were given recombinant FSH prior to the pulsatile GnRH, they had a better sperm concentration. You can see that these blank circles are the patients who are given recombinant FSH before they were given pulsatile GnRH, because once the patient is given pulsatile GnRH, it is going to produce LH as well as testosterone. So before the onset of testosterone, if you give just FSH, there is a beneficial effect in this small study published in 2013. And similar experience has been with in our department. So we have got almost 40 patients with who are treated with gonadotropins, and you can see that those patients who are given just FSH prior to the combined treatment, they had a better sperm concentration. So you can see that the other groups who are given combined gonadotropins, that is FSH as well as SCG at 0 hours, compared to these patients, the HMG pre-treated patients had a better spermatogenic potential, and this number is now almost 7-8, and that data is being collected. So apart, if you exclude these 5 patients, the rest of the patients become 35, and this 35 patients were separately studied by our recently passed out resident, Dr. Ravi. And if there were 2 groups, one is pubertal induction group. So in these patients, gonadotropins were used to directly induce fertility, induce the puberty. So these patients were not exposed to the testosterone. Compared to other group in which these patients were already given testosterone for very long duration. Now these patients they came for the fertility point. So these 17 patients were in the pubertal induction and 18 patients were in the fertility group. So if you just study the severe phenotype, so any patient with baseline testicular volume of 4 or less, if these patients were given if these patients were given combined gonadotropins, that is HMG as well as SCG, before they were given testosterone, the response was much better. You can see that the number of patients reaching more than 1 and more than 5 million is much higher in patients with the patients in pubertal induction cohort. And what is the difference? So these patients were never exposed to the exogenous testosterone before they were exposed to the gonadotropins. So in patients with severe phenotype, if the patients are exposed to the testosterone for a longer duration, there can be a detrimental effect on the Sertoli cells as well as seminal tubules, impacting their future fertility. So we need to keep this particular point in patients with the CHH patients with severe phenotype before we start them on the definitive treatment. But so in patients with severe phenotype, prior testosterone has a adverse outcome, poorer outcome. But when you study partial phenotype, so partial phenotype means any patient with baseline testicular volume of 4 or more ml. So if the testicular volume is very good, it is indirectly suggesting that the patient has a good number of Sertoli cells. So even if these patients are exposed to the prior testosterone, the spermatogenic potential is not very different. So in patients with the partial phenotype, even if you expose these patients with the testosterone, the outcome may not be very different, but it is different in patients with the severe phenotype, and we should remember this point in our practice. And this particular paper is recently published in the Pituitary Journal just a few months back. So based on this experience, now we have modified our pubertal induction protocol in our severe phenotype patients. So patients with testicular volume of 4 or less ml, 4 or less. So in such patients, we always start with FSH, but recombinant FSH is little costlier, hence we use HMG. We start with 75 units thrice a week, and after 3 months, we check the inhibin B level. If the inhibin B level is very good, if it is more than 100, and last few slides. If it is more than 100, it is adequate response, and we start the patient on the low dose SCG. And if the response is poor, we increase the HMG to the 150 units thrice a week, and then we add subsequently the HSG. And the final dose of SCG should be 2000 thrice a week. Any higher dose like 10,000 or more is not going to produce any better response. So this should be the maximum dose in most of the patients. And the endpoint is adequate utilization as well as testicular volume, which is at least 10 to 12 ml, or it is not increasing further over a period of next 6 months. And once we achieve this induction, we can shift the patient on the androgen therapy or the SCG therapy. So in our patients with severe phenotype, we start with the FSH pre-treatment and then only add the SCG. And in partial phenotype, we can start with the combined treatment. And as discussed by Anurag sir in last talk, in patients with acquired hypogonadism, they can have a FSH sparing effect. And in such patients for induction of fertility, you can use the SCG alone. So that is the end of the talk. Yeah, thank you.
Thank you, Virendra. We have time for questions, no?
Yes, there are a couple of questions.
Yeah, you can ask.
This
So
one
one
is,
question, yeah.
This one is for Dr. Anurag Leela. In suspected PCOS, where there can be mild rise in prolactin levels, but as we know, PCOD is a diagnosis of exclusion. So how to say it's because of PCOD or because of hyperprolactinemia, which are causing menstrual irregularity?
So, as I had mentioned, that a subtle rise in prolactin between 25 to 50 should be primarily because of PCOS. And we can look at the LH and the FSH values, which can give us a clue whether it is a primary prolactin. So, looking at the LH and the FSH values, if the LH and FSH value are lesser and the LH is less than the FSH, it is more likely a prolactin thing. And when the LH is more than the FSH, it's going towards the PCOS. So, these are subtle points which we have to take into consideration when we make a diagnosis.
Another question from Dr. Amey Joshi. What was the size of resistant prolactinoma subjected to surgery and indications for surgery in prolactinoma?
So indication for surgery in prolactinoma to my mind is any size of the tumor. We start with cabergoline. We admit the patient in our ward and monitor them to see the response, and the mass effect goes down. So any size of the tumor, the size is not a criteria to subject the patient to surgery. In case patient gets into a CSF rhinorrhea on follow-up is one reason to subject a patient to surgery. So when the surgeon goes for the floor repair, at the same time we ask them to debulk the tumor in the same setting because it is feasible. And in case the mass is not regressing on size and the mass effect is persistent, those are the only cases where subject them to surgery and radiotherapy. In these cases, we stop cabergoline then.
Okay.
And the cases like which I have shown, like co-secreting with growth hormone, co-secreting with ACTH, or a cystic prolactinoma not getting response to the cabergoline treatment.
Okay.
We have to move for next session from pituitary to adrenal.
Yes.
Thank you, Madam and Ganpati sir, for sharing the session. Now we are inviting Dr. Parag Shah sir and Dr. Gandhi sir to chair this session. Pramod Gandhi sir is a senior endocrinologist from Nagpur. He has been a secretary for Maharashtra Endocrine Society and he was executive committee member from Endocrine Society of India. He is alumni of KM. I welcome Pramod sir along with Dr. Parag Shah sir. Parag Shah sir is a practicing at Gujarat Endocrine Center, Ahmedabad from past 20 years. He has been organizing secretary of ESI in 2015. He has more than 45 publications in index peer reputed journal and he is involved in more than 40 landmark trials. So I welcome Dr. Pramod Gandhi sir and Dr. Parag Shah sir to chair the session. Thank you.
Thank you.
Thank you. Thank you. Thank you,
Yes,
sir. At the outset, I would like to thank the ESI Satellite Symposium team for inviting us. Let's start with the next session, which is on adrenals. For this session, the first speaker is Dr. Swati Jadhav, and she's going to talk on approach to adrenal mass, CT scan, interlocking tab to diagnosis. So Swati is a associate professor at KEM Hospital, St. GS Medical College and KEM Hospital. All of us know Swati very well. Over to Swati.
Please unmute.
So, is my slide visible?
Yes.
Yes, yes.
And I'm perfectly audible, I guess.
Very much.
Yeah.
Yeah,
So,
yeah, yeah. very much.
A very good evening to everyone, and I'm very happy and thankful to the organizers of ESI Satellite Symposium team to have given me this platform, specifically so because it bears the name of Dr. Bhandarkar sir, and it gives me a platform to share with my colleagues, dear colleagues at KM. So adrenal mass, when we say adrenal mass, it's a very common problem. So much common that in the past decade, we have at least 4 to 6 consensus guidelines, white papers by various organizations which guide us to say how to deal with this problem. But how common is the problem? That depends on how we decide to look at it. So prior to 1970s, when CT scans came to use, prior to that, in whole of the published literature, there were less than 200 clinical described cases of non-secretory adrenal tumors. And when CT scan became available and became routinely used in 1970s, thereafter in various radiological studies, which are specifically CT-based studies, the prevalence of masses are close to at the max 4%. Now, this is a huge prevalence, considering that we all work in parts of, in cities where at least a number of city centers are working and doing at least 100 scans a day. We expect 2 to 4 patients of adrenal incidentalomas to come to us. So it has that magnitude of a problem. So how we encounter an adrenal mass, in my mind, it's very simple. Either we seek out the mass or the mass seeks us out. Now, the first scenario, when we seek out the mass, this is how the traditional conventional endocrine teaching goes, that a patient comes with the clinical symptoms and signs of either hypo or hyper functioning of the adrenal gland or any gland. We do a relevant hormonal investigations and we have made a certain clinical diagnosis in our mind, and then we do directed specific radiological investigations, and that takes us to the final diagnosis. Now, what hyper and hypo functioning in terms of adrenal gland, my audience is too elite and too learned today for me to spend any more time on this slide, which enumerates the various hyper functioning and hypo functioning syndromes of different layers of adrenals that we know of. The other scenario, when the mass seeks us out. Now, this is the scenario of a true incidentaloma when the CT scan has been done for other indications other than a suspected adrenal pathology, and there we are faced with this situation of an adrenal mass which looks at us, and it is our responsibility to pluck through all the clues and get to the diagnosis. Now, this scenario can, for convenience sake, can be divided into 2 setups. An oncology setup where CT scans are routinely done either as a part of disease mapping of the primary tumor or done at varying points of times during the therapeutic response monitoring. And the other scenario is non-oncology setup, which is coming up very rapidly now as a part of just routine annual checkup when a USG is done, which reveals a adrenal mass, or in various causes of abdominal pain syndromes. Now, I will quickly take you through the journey of our understanding of adrenal CT right from early 1940s. During those times, the way the people used to look at adrenals was doing a retroperitoneal air insufflation and then taking X-rays at various angles to with an attempt to look at how the adrenals look. This was followed by attempts at cannulating the adrenal veins and doing adrenal phlebography or doing a renal arteriography with an attempt to look at the morphology of the lesions, guessing from its vasculature. Then iodocholesterol scintigraphy gave some idea about the functioning of the adrenal cortex. And then in 1970s, when the adrenal CT scans came up, there were detailed studies which delineated the precise morphology of even the normal adrenals. Now, with the advent of CT, the lesion detection became very easy and, more importantly, very frequent. And now the onus of responsibility went from lesion detection to lesion characterization. The radiological characterization of the lesion, by that we mean to be able to differentiate on the basis of radiological characters the benign lesions from the malignant ones. Now, benign lesions are predominantly adenomas. Because the other benign lesions like myelolipomas and cysts, they have very characteristic radiological features which make their diagnosis very easy. So it is only adenomas which sometimes pose a diagnostic challenge. As against the malignant group, which is termed as non-adenoma group, which in earlier studies mainly consisted of metastasis because those were the oncology series patients. And later on, the other malignant adrenal masses like adrenocortical carcinomas, pheochromocytomas, and lymphomas to that extent came in this group. Now, what parameters do we have to rely on to make this radiological differentiation between adenomas versus non-adenomas? They are a morphological parameter like the size and the attenuation, the HU values. When we talk about the size, we know that adenomas are smaller lesions, mostly smaller than 4 centimeters. But having said so, non-adenoma masses have a significant overlap in size with adenoma masses, rendering the size a less useful parameter in this differentiation. Then the next parameter we look at is the attenuation value. The baseline attenuation value, we all know the determinant of that is the lipid content, the fat content of the adenoma. More lipid rich the adenoma, darker it will look on the CT scan and lesser the HU it will have. To signify that, a lesion which is having a baseline HU of 0 will give us 100% confidence that it is benign adenoma, but only 40% of those adenomas will have such a characteristic. So coming to a optimum threshold, we know that conventionally baseline HU less than 10 gives us a specificity of 98% for saying that it is a benign adenoma with a sensitivity of 70%, which is acceptable, but which also means that 30% will be lipid poor. They will have baseline HU more than 10, signifying the need for looking at other parameters. Now, the other parameters which we look at are the attenuation values at various time points after we give the contrast parameters. So how do we do an adrenal protocol CT at our institute is, we do an unenhanced phase CT at baseline, we take a scan, then we give the contrast, and after giving the contrast at 20 seconds, we take another scan, which we call as arterial phase. At 60 seconds, we take the third scan, which we call as the early venous phase. And at 15 minutes, we take another scan, the last scan, which we call the delayed venous phase. Now, in characterization of the adrenal masses, the different parameters, the HU values at different phases have been studied to see how they help us in differentiating adenomas versus non-adenomas. So far as unenhanced phase HU is concerned, we had just discussed that unenhanced phase has a great value in detecting adenomas if it is less than 10 HU. The next parameter which was studied was early venous phase, 60-second early venous phase HU values. But when it was seen, similar to the other things which what we noted was there was a significant overlap between the early venous phase HU value between adenomas and non-adenomas, signifying that both adenomas and non-adenomas by 60 seconds take up contrast to a similar extent. So making this HU values at early venous phase less useful for us to make the differentiation. The next which was studied was a delayed venous phase HU values. Now these delayed venous phase HU values had some utility because it was seen that the non-adenoma group had retained the contrast by 15 minutes to a greater extent, giving rise to higher HUs than the adenoma group. And different studies propose different threshold cutoffs to suggest that what level of delayed venous phase HU should be there to call it confidently a adenoma. And various studies have given a cutoff from 24 to 30, giving a sensitivity of and specificity which is quite reasonable for that. Now, the other parameters which we all know of are washout parameters. Now, washout parameters, what it means is when a lesion has taken up the contrast at 15 minutes delayed venous phase, what amount of contrast or what percentage of contrast that it has taken by early venous phase has it given away or has it washed out. That is what we call as the washout percentages, the relative and the absolute percentage washout. Now, a landmark study which came up from the Michigan group in 1996 gave us what we routinely know today, the thresholds for absolute and relative washout percentages. Absolute more than 60% and relative washout more than 40% is what is indicative of an adenoma with pretty good specificity, 96 to 100%. And sensitivity in this study was also good and acceptable from 88 to 96%. Several studies after this study was published confirmed the findings, which made us understand that adenomas are good washout masses. But later studies which came up with significantly larger number of adenomas have challenged the sensitivity of 88 to 96%. And according to those studies, it was seen that around 20 to 30%, this is an average figure, it might range from 5% to 45% of adenomas are actually poor washout adenomas. So with that in mind, how do we summarize the radiological approach to adrenal masses? The adenoma 70% will be lipid rich, stating that baseline HU will be less than 10, and 30% will be lipid poor with baseline HU more than 10. In this group of lipid poor adenomas, we do washout studies and we will get the answer in 80% of the patients, which will be good washout. Around 20% of the patients will have poor washout with absolute and relative percentage washouts less than 60 and 40%. How do we approach this poor washout lipid poor adenomas? It is individual case to case basis. For us, if the patient is having, if an adenoma is well looking, 3 centimeters homogeneous mass without necrosis, without anything, patient is asymptomatic, we might even decide to observe these patients for at least 6 to 8 months to demonstrate an interval growth of the lesion. In radiological literature of adrenal masses, stability of the size of the lesion over a period of 6 months to a year is considered to be diagnostic of a benignity of the lesion. That approach can also be undertaken rather than an aggressive approach of either biopsy or surgery. When it comes to non-adenomas, they are lipid poor lesions with baseline HU of more than 10 and they would have poor washout. And this behavior is very well followed by metastasis, ACCs and lymphomas. But when it comes to pheochromocytomas, these are called as a radiological chameleons. They have all pervasive radiological characteristics. They can have good washout as well as poor washout, and they can even have a baseline HU less than 10. The case reports of such POs do exist. Now we at KM Hospital, Mumbai, we have got a law, we frequently get referrals for pheochromocytoma, so much so that over the years we have accumulated a database of several hundreds of patients with pheochromocytoma. That gives us an opportunity as well as responsibility to see how we can characterize radiologically this interesting group of adrenal masses, the pheochromocytoma. So as we have just now discussed that the washout parameters as well as unenhanced early venous and delayed venous phase HU parameters have been studied for pheochromocytoma, and they do not help us differentiate with other lesions. But what has been lesser studied and lesser appreciated and talked about are the arterial phase parameters, the HU parameters in the arterial phase, and the wash-in parameters. Rather than talking about how much a lesion has washed out contrast, how much has it washed in or taken up the contrast from baseline level is what wash-in parameters mean. So at KM, we decided to undertake this study, and this was entirely the brainchild of our beloved colleague, Dr. Manjunath Goroshi. He tried to establish the radiological features of pheochromocytoma, which can differentiate it from other malignant adrenal masses, not adenomas, and specifically paying attention to the wash-in characteristics. So we had 72 adrenal masses, 33 of them PHOs, 22 of them adrenocortical carcinomas, and 13 adrenal metastases. We had few adrenal lymphomas as well. So what we found out in the study was how the pheochromocytoma as a group behave in terms of taking up the contrast and giving away the contrast when it is compared with other adrenal masses like adrenocortical carcinoma, lymphomas, and metastasis. So as is clearly seen in this figure, at baseline HU does not help us differentiate between these groups of masses. But pheochromocytomas being very vascular masses, they are very enthusiastic in taking up the contrast. They take up the contrast a lot of contrast and a lot early, so much so that the peak enhancement is achieved at arterial phase when the other masses are still taking up the contrast, and achieve the peak enhancement in venous phase when the PHO has already started washing out the contrast. So based on these characteristics, we try to look at the wash-in parameters which have got very good specificity for diagnosing it to be a pheochromocytoma. What we had seen that peak enhancement in arterial phase is a feature of PHO, while the other masses have peak enhancement in venous phase. In other words, the enhancement in our HU value in arterial phase for PHO will always be greater than venous value. For others, venous will be higher than arterial phase HU values. Then another thing which we had seen that all the PHOs have absolute HU value more than 100, while all other masses had it less than 80 and 60 in arterial phase. Like we calculated the percentage washout parameters, we calculated a percentage wash in arterial enhancement parameter, and we have found that with the cutoff of 100%, the specificity for diagnosing PHO was 100% in our group of patients. We were happy that we were able to publish our experience in a reputed journal. To summarize that by doing this study, we were able to add one extension to the parameters, radiological parameters of adrenal masses, to say that PHOs are rendered recognizable by certain wash-in parameters like arterial phase HU more than 100, the percentage arterial enhancement more than 100%, and the arterial phase HU being more than venous phase HU is what indicates a pheochromocytoma. With that understanding of the CT of adrenal masses, I would now like to share a few interesting experiences that we had at KEM about the adrenal masses. I would have loved if this had been a physical interactive dialogue rather than a monologue, which online setup offers. Now, this patient, 50 years old, was on follow-up at TMH, Tata Hospital, for management of CA lung. And during any point of his workup, he was done an FDG PET CT scan, which revealed a right adrenal uptake. If you can appreciate, this right adrenal mass is slightly enlarged, and the morphology of the lesion is like infiltrative adreniform shape. The other adrenal was okay. And if we look at the washout parameters, it was plain HU was 40, it was a lipid poor mass, and the washout was poor. And in the setting of primary extraadrenal malignancy, such morphology and such washout, it's easy to say that it might be a metastasis. A biopsy was done and it was proven to be a metastasis. Another patient, now this patient, though not precisely in oncology setup, but she had presented with abdominal pain, which revealed this mass. Now, if we look at this mass again, it is a poor washout mass, but almost simultaneously, she was also found to have a lung carcinoma, and this was also a case of metastasis, signifying that metastasis need not always be a small bilateral adreniform shaped. It can grow to a larger extent depending on how late we diagnose them. Another patient, an operated case of CA carcinoma, was on follow-up with Tata Hospital, referred to us for this small adrenal lesion. If you look at it, the plain HU is 15, which is close to benignity, though not exactly benign, it's lipid poor only. But the washout patterns were good, giving us a confidence that this might be an adrenal adenoma, and we decided the patient to follow up and do radiology after certain interval to document an interval growth. Another patient, a CA penis patient, this time referred to us for a similar looking adenoma as that of the previous patient. But here, if we look at the arterial phase HU was 94, though not 100, but close to 100. The arterial HU was higher than the venous HU, which made us think that it might be a PHO. We calculated percentage arterial enhancement, it was more than 100%. So we thought it as a pheochromocytoma. We ordered a norepinephrine level, which came high, confirming our diagnosis to be PHO, operated, and it was indeed a pheochromocytoma. Another patient, a lymphoma. Now, lymphoma, before chemo, he had underwent a FDG PET CT, which had shown FDG positive multiple lymph nodes throughout. Additionally, the adrenal mass was also there, which was very FDG avid. Considering this, this mass was initially considered to be a part of his general lymphoma burden. But he received chemo, and post-chemo FDG PET showed very good response to chemo in terms of resolution of other masses, but this adrenal mass remained. And then he was referred to us for evaluation. We did a proper adrenal protocol CT, in which we saw clearly that arterial phase HU is way high, 205. Arterial HU is more than venous HU. The percentage arterial enhancement was way higher. For us, it was a pheochromocytoma, proven by doing a metanephrine level, and he was operated, and HPR indeed came out to be pheo. On similar lines, another patient, incidental detection of such mass. Now this is again, arterial phase is higher. We feel that it is PO, arterial more than venous, but we did metanephrine levels and they came out to be normal. But so much so was our confidence in our findings that we went ahead and did even an MIBG scan to see whether it was PO, but it was negative. So we did an FDG PET CT, which revealed this the FDG uptake in multiple bones like scapula and bone, as well as soft tissue around the hip joint. The biopsy from this lesion as well as from the adrenal mass proved it to be a sarcoma. Now, this was an important learning point for us, because we have encountered this patient after publishing our radiological workup for pheo, and the radiological pheo is bright because it is very vascular, and the differentials for a hypervascular adrenal lesion are very few. Pheo tops the list, and others being metastasis from a renal cell carcinoma, hepatocellular carcinoma, or a sarcoma. And this patient was indeed a sarcoma patient, which led to a hypervascular adrenal metastasis. Coming to the non-oncology setup, very common scenario, the CT being done for some unrelated reason. For this patient, it was constipation. And this was the morphology of the lesion. Very well circumscribed, although there is one speck of hyperintensity, but overall the plain HU was less than -5. Now, was less than 10. It was actually less than 0, -5. This gives us pretty much confidence that this is an adenoma and we need to follow this patient. Another patient did the CT for abdominal pain. If we can see, this was the lesion. Again, the washout parameters were poor. It was a lipid poor mass. But if we look at the arterial phase, the HU was 128 higher. Arterial HU higher than venous HU. We thought it was pheo, and indeed the metanephrine levels were very high. HPR was pheochromocytoma in this patient. Now this mass, the way it looks at us, by just looking at the lesion, the heterogeneous mass with areas of necrosis, such a huge tumor, it was ACC without the need even for these poor washouts. His DHEAS levels were high, post-operatively they came down, HPR indeed came as adrenocortical carcinoma. This patient, young patient, abdominal pain, USG followed by CT done. Now this lesion, if we can see, it looks cystic, but what confirms it to be cystic is look at the HU values. The HU values do not increase at all. Even till the delayed phase of 15 minutes, the HU values are remaining almost the same. In radiological literature, if the difference between the HU values are less than 5, it is taken to be as the same HU values. So the same HU values till the delayed phase gives us confirmation that it is a cyst in this case, and in this case, because of the size the patient underwent excision, it was indeed proven to be an endothelial cyst. Similar cystic lesion as was the case in previous patient. Now, if we would have kept the ROI in the center of the lesion, it would have uniformly came somewhere around 5 to 10. And it would have been same, and we would have labeled it as cyst. But as in contrast to the previous patient, the rim of the lesion is quite thick and it is enhancing. When we put carefully the ROI for taking the HU value on the rim, it came out to be arterial phase as 125. Again, arterial more than venous, higher PAE. We thought it to be pheo, and we ordered a metanephrine test, which came out to be normal. Confirmed twice, it was still normal. We went ahead and did an MIBG scan because we had very much faith into our parameters of pheo, which we had studied. It came out to be positive. He underwent surgery, and it was indeed an pheochromocytoma. The reason we believe for the normal normetanephrine levels might be an extensive necrosis and lesser number of cells left for producing the metanephrines. Another lesion, subcostal pain, and then this is the mass that we see. Now, the characteristic feature of this mass, the size of the lesion and would make us think whether it is an ACC, but there is one thing which is very peculiar in this mass is the contrast is progressively increasing from plain to arterial to delayed venous. Even at 15 minutes, the mass is continuing to take up the contrast, and such progressive contrast enhancement is typical of a neurogenic tumor. So we operated this patient and indeed turned out to be schwannoma. So this, in our study, we found that progressively increasing the HU mass is what gives us a preoperative confidence of it to be a schwannoma. Now another patient, 48 years old, who presented with severe flank pain and clinical symptoms of adrenal insufficiency, which was proven biochemically. It was a bilateral adrenal mass, a poor washout bilateral adrenal mass. When the lesion becomes bilateral, our way of looking at it changes because the etiology changes. For a unilateral mass, the most common etiology is adenoma, but when it comes to bilateral, the etiological spectrum changes. These two masses were very FDG avid, and on biopsy it turned out to be B-cell lymphoma. Another patient, systemic symptoms, bilateral masses, enhancing heterogeneously on FDG PET CT, and here this turned out to be histoplasmosis. We had published our experience about the bilateral adrenal passes in 70 patients. Bilateral pheochromocytomas were the most common etiology in our group of patients, followed by tuberculosis, lymphoma, metastasis, and only 3 patients with bilateral adenomas. So this is another patient. Now we have to be clear. Sometimes we get across such tumors which we call as pseudoadrenal tumors. That means they are not adrenal tumors, but because of the characteristic location in that adrenal fossa, they might look like an adrenal mass, as was the case in this patient, which ultimately was proven to be hepatocellular carcinoma. With that, I would like to conclude that indeed CT plays a very important role in helping us understand what kind of lesion it can be, and in association with the clinical evaluation, the hormonal test, the functional imaging, it helps to plug everything together and reach at the final histopathology. Thank you.
Thank you, Swati, for that excellent review on the radiological, or I will say CT scan evaluation of the various types of adrenal tumors. I think it was really an eye-opener session. I think we should move on to the next session, that is on primary aldosteronism, intricacies in the diagnosis and the management. This talk will be delivered by none other than Dr. Tushar Bhandarkar, who is Professor and Head, Department of Endocrinology at St. GS Medical College and KEM Hospital. I think Tushar doesn't need any introduction. He is very well known and very popular person amongst all of us. Over to Tushar. Tushar, you are muted. You need to unmute.
Yeah. I'm trying to share my screen.
Yeah.
So, can I open this? It's not showing. Files. Desktop.
Yeah. You could see your screen. Yeah. Yeah.
Okay, I'll just put the. It's done?
Yeah, it's done.
And the slides are visible?
Yes,
yeah,
yes.
Very well.
Sure.
You are audible as well.
Thank you. Thank you for the nice introduction. And I'm going to speak on primary aldosteronism, intricacies in diagnosis and management. To introduce the topic, I'm sure we all know that it's primary aldosteronism is fast turning out to be the most common cause of secondary hypertension, and few experts say that it is becoming one of the commoner causes in the complete hypertension subgroup as well. When you talk of PA, we know about adrenal cortex, and I'm going to restrict to glomerulosa, which secretes aldosterone, which we all know, which leads to primary aldosteronism. Now, aldosterone was isolated in 1953, and in next 3 to 4 years, Jerome Kohn described this classical syndrome of which is called as Kohn syndrome, where the patient came with hypokalemic paralysis, hypertension, metabolic alkalosis, and this was completely reversed with the adenoma excision, and journey of Kohn syndrome began after that. They've seen a lot of ups and downs, and the interest in Kohn syndrome has had resurgence since few years. When you talk of Conn syndrome, immediately it comes to the mind that things are very difficult, and we've always been taught in medical schools that it's very rare kind of tumors, and it's very difficult to kind of evaluate these tumors. But the basic concept is what we need to understand is that it works on two major players. One is renin and one is aldosterone. This is a low renin hypertension where aldosterone is autonomously high. So in the face of low renin, there's no business for the aldosterone to be there. And if the aldosterone is there, it means that it is coming out from the gland, which is autonomously secreting and needs to be out. So for describing our experience in diagnosis and management, few facts needs to be known. The first one is about pathophysiology. We know about this aldosterone, which works on mineralocorticoid receptors and leads to increased sodium absorption, volume expansion, and increased blood pressure, which ultimately would suppress the renin and angiotensin and would prevent the proximal renal, the tubular absorption of sodium. This leads to increased distal delivery and ultimately causes loss of potassium as well as H+, leads to metabolic alkalosis. And all these pathophysiology is the one which leads to increased cardiovascular and kidney disease, which is the crux of primary aldosteronism, which we try to treat. It has been very clearly shown that if you compare patients with essential hypertension versus those of PA, and if you look at cardiovascular events and target organ damage in them, it's shown very clearly that PA will have more of these events compared to essential hypertension independent of the BP control. With the same BP, they will have more problems, and this is aldosterone specific toxicity. And mind you, this high aldosterone alone is not really doing much of a damage. It's because of that link of sodium excess which exists with hyperaldosteronism in case of PA, which is responsible for this cardiovascular damage. So one of the most important strategy to reduce the morbidity and mortality is to restrict sodium intake, and you would have reduced a lot of damage of these patients when we really treat this patient. So it's one of a very important diagnostic as well as management issues which needs to be looked at. Epidemiology, as I was talking about, right from our medical schools, we've been told that this phenomenon is quite rare, less than 1% of total hypertensives. But more and more studies have really questioned this dogma and have clearly shown that it's not rare anymore. It's becoming one of the most common cause of secondary hypertension. This was a study in Italy where it was done in hypertension clinic, where they looked at approximately 1,700 patients, and they used a two-step approach of looking at a screening test and a confirmatory test. Screening, they use a standard ARR or PAC by PRA ratio, which we call, and whoever positive were subjected to a confirmation test with IV saline, and of which 100 turn out to be positive. So the prevalence was deemed to be 6%. So definitely, which is what has been taught in books is not anymore true. Minimum, we talk of 6% of PA in a case of hypertension is a big number, and it depended upon the severity of hypertension, stage 1 hypertension to stage 3, where stage 3 it was around 12%. These things have also been replicated in other studies where prevalence has been around 10 to 20% in case of resistant hypertension. Even AIMS data, which is just published now, where they looked at young hypertensive patients, prevalence of PA was to the tune of around 20%. So we are all talking the same language world over as well as in India. And we need to know that we are dealing with a very common disorder, which we need to screen. Guidelines tell us to screen only the severe kind of overt presentations, but those with milder hypertensions are not really looked at. And we may be really missing a lot of number of patients which may get their due credit if diagnosed properly on time, and the complications can be prevented. What does guideline tell us? That if you have a severe kind of hypertension, resistant hypertension with adrenal mass, or there are family history in a case of young hypertension, you need to definitely look at it. But more and more experts are coming to the term to say that in case of any case of hypertension, once in the lifetime of a hypertensive, we need to at least screen for primary aldosteronism, and it's not difficult to screen it at all. We just need to do a renin and an aldosterone level. With the availability of various assays which are chemiluminescence based, it's quite simple to do it, and it's worth the amount of money as well as the amount of benefit which we can accrue out of it. So with that background, let's look at how to diagnose them. We've earlier been using plasma aldosterone concentration as well as the plasma renin activity, which is what had been taught to us from earlier days, which were earlier being done by immunoassays. Now we have both these tests, aldosterone as well as renin in the form of renin concentration, available as a chemiluminescence technology, which can be very easily available, and they have a very fast throughput. It's like T3, T4, TSH being available in chemi assays, and it ensures that rapidly when you talk of 6% of prevalence of hypertension and you need to screen so many patients of hypertension, you need a test which has to have a good throughput as well as fast kind of answers to that. And we would do the test in a screening mode first, followed by a confirmation test. So what are the nuances or what are the learning points I'm going to share with a few cases which we are going to see now. Let's look at this patient, first case, who is a 26-year-old lady who has come with recurrent episodes of hypokalemic paralysis, and because of that, she was put on aldactone. And the screening was done with PAC, the aldosterone as well as DRC, and potassium was 3.2. And the other patient, who is 52-year-old male who has got hypertension and who is on 3 drugs, losartan, HCT, and amlodipine. Aldosterone levels were 19, PRA is less, potassium is 3.9. The immediate question comes to us, how do we stop these medications, or how do we interpret? Whether can we interpret these values? We need to give high salt diet, potassium replacement, stopping the drugs for X amount of days, and that's where all the controversy starts. And then you realize it's not easy to do it, and patient may really leave the doctor if you try to do so many tests or try to stop the medications. The blood pressure goes up, and that's been a common practice. So that's how it has been very clearly shown now that what needs to be done is not to stop the medicines, and let's look at what transcribes out of it. When we do a screening test, we ask for renin as well as aldosterone, and as guidelines say, we have to do a ratio. Instead of looking at ratio, we have to look at these 2 tests separately. You look at plasma renin activity. If it is suppressed, then your diagnosis of low renin hypertension is made, and in that phase, if your aldosterone is more than 10, then the diagnosis of primary aldosteronism is clearly made. There's no reason why aldosterone should be that high in a phase of renin suppression. People want to take the level of aldosterone lower and lower to 6 and all with the latest studies, but at least 15 is definitely diagnostic, and definitely 10 is also a criteria which needs to be looked at of aldosterone levels in the phase of renin suppression, and ARR is not really sensitive enough to pick these cases. So when we talk of, as I was talking, it's always in our mind about prerequisite before testing for ARR. We need to do the test early in the morning. It's you have to be up and about. Patient has to be up and about for around 2 hours after getting up, and then you need to make the patient sit for 10 minutes and collect the blood for aldosterone as well as DRC. Ideally, try to normalize the potassium and liberalize the sodium intake. It may not be possible in routine scenario. Our diet itself contains a lot of sodium nowadays, and we are all having salt quite liberally. And about the drugs, most of the drugs which we are used as a treatment for hypertension will increase the renin, and only beta blockers and central sympathologics decrease the renin. So if you get a renin which is suppressed, in spite the drugs are going on, you can interpret the test, and you can don't have to repeat the test or stop the drugs at all. But if you are not sure, if the renin is not suppressed, and if you are very clear that the clinical suspicion is very high, then you need to stop the drugs for 6 weeks for MRAs and 2 weeks for ACE and ARBs. Definitely liberalizing salt intake further would add on. About confirmation test, there are myriad of tests which are available, but what we use is seated intravenous saline suppression test, where around 2 liters of normal saline is infused over a period of 4 hours with patient in a seated position, and we do various cortisols and aldosterone pre and post. If the post infusion aldosterone level is more than 6, the diagnosis is clearly made. Other tests like 24-hour urinary aldosterone level after giving oral sodium suppression is also one of the tests which has been advocated, where if your 24-hour urinary aldosterone is more than 15 microgram, 12 microgram per 24 hours, then the diagnosis is made. But mind you, experts want to make things very quite simple and not make it complicated. They think that confirmation test may not be required if there is a very strong clinical evidence of a severe kind of presentation where there is hypokalemia. If PRA is suppressed and aldosterone level is more than 20, then you don't require any confirmation test. Even one test is done and you can go ahead and start treating the patient. So with this background, let's solve the issue with these two patients, the diagnostic based one. First one, this lady has hypokalemia. You have renin, which is suppressed on aldactone. So if the renin is suppressed, you don't have to really stop aldactone. We accept that this is a low renin hypertension, and with such high aldosterone, more than 15, 10, whatever you take, it's primary aldosteronism, and you can interpret that. Diagnosis is made, and confirmation test is not required because aldosterone is more than 20. So we go ahead and straight away go for imaging. Imaging shows left adrenal adenoma, and she's subject to left adrenalectomy, and post-op she's really cured. You talk of the second patient who's on 3 drugs. Renin is suppressed. In spite of these drugs being there, if renin is suppressed, that means you can go and interpret this particular test as positive test, and then we go ahead and do a confirmation because the levels are not that high. Aldosterone level is less than 20 as such. That's a cutoff which is arbitrarily put there. And we do a confirmation test which says that it's not really suppressed. It doesn't get suppressed. That means PA is confirmed. Do an imaging. Imaging shows bilateral nodules, and the patient is put on medical therapy. So the crux of diagnosing is that we don't need to stop any drugs. We just go ahead and do renin as well as aldo. If renin is suppressed and aldo is high, your diagnosis is made and you can go ahead. Once you're biochemically confirmed, then we need to see where this autonomous aldosterone is coming from, and that's called as subtyping of the patient, where the cause can be bilateral in most commonly seen in 60%, or APA unilateral in 30%, and there are various genetic causes depending upon the age of presentations. And we would ask for CT scan and as and when required, adrenal venous sampling. What the CT scan tell you is that if you get a single adenoma on one side and no adenoma on other side in a young patient, then it's really diagnostic. But most of the time, you don't really get any abnormalities because bilateral adrenal hyperplasia is more common kind of scenario in the current world. So you may get mild bumps here and there on the left and the right, or that could be completely normal. And this is where you require an adrenal venous sampling to really sort out the issue, whether it's right-sided or left-sided or it's both-sided. We have established this technique and it's running quite successfully for patient care at KEM Hospital, where a trained interventional radiologist who only does a single person who does this procedure repeatedly for years, and he's become very comfortable with that procedure. What essentially is done is the catheters are advanced through the femoral route to bilateral adrenal veins to the right as well as to the left. Cannulating the left one is easier, right one is a bit difficult, and we need to be sure that we are inside the vein. And that's how we look at then levels of aldosterone and cortisol from these sampling. So to know that whether these adrenal veins have been catheterized properly or not, there's a particular index which is called a selectivity index, which means that they would look at a cortisol levels from this adrenal vein and divide it by the peripheral vein cortisol. If it is more than 5 times that of the peripheral vein cortisol, that means the catheter is inside the adrenal vein, and you can interpret or analyze the aldosterone values which can be taken. So once you know that catheter is inside, then we look at the aldosterone values from both right and left, and we try to divide the higher one by the lower one, and that's called as lateralization. The higher aldosterone value from the side of that gland should be more than 4 times than that of a lower one, suggesting that there is an autonomous secretion from that higher side gland, and which is called as the lateralization index. And the third important index is contralateral suppression index, where the non-dominant gland is supposed to be completely suppressed. So it's going to have aldosterone values which are less than that of IVC or peripheral aldosterone. So if it's less than 1, when you divide that, then that's called as a contralateral suppression. And all these 3 indices are required are essential to designate which gland is the culprit and remove that kind of gland. What we do with us is we give a sequential adrenal venous sampling under continuous STH post-entropin infusion, which is started 1 hour before the procedure and goes throughout the procedure. And we do an intra-procedural serum cortisol confirmation, where the radiologist and are waiting for the cortisol values during the procedure, which takes half an hour approximately to get that value to see whether your catheter is inside, and then the blood is collected for ultrasound. So it has all been typed with us. Since it's an invasive procedure, it's done in expert centers as such only, but looking at the number of patients, many of the patients may not be able to be subjected to adrenal venous sampling, looking at 6% prevalence at least to the least. And that's where experts say that if you have a clear-cut evidence of a severe case, then AVS may not be required, especially if you have a unilateral adenoma with no adenoma on one side and normal adrenal gland on the other side with severe case and in young patients. Because as the age increases, then the bilaterality of the lesions as a normal physiology of aging starts increasing, and hence you may be wrong if you do not use AVS when the age is more than 35 years to begin with. So I'm going to show you cases now which we have managed at KEM Hospital and give you a snapshot of it and give a learning message with each case what we have gone through. So look at this lady who is young and who has hypertension and hypokalemia. Biochemically, she is completely diagnosed as PA. Aldosterone is more than 30. Hypokalemia, young, less than 35 years of age. You do a CT scan, shows left adrenal adenoma. Right side is not showing anything. So this case doesn't require confirmation. One screening test is enough. This case doesn't require confirmation. And this case doesn't require any adrenal venous sampling. And you can go ahead and operate this patient. Post-surgery of left adrenalectomy, she was completely cured. One more thing I would like to showcase here is that we have shifted from open surgeries to laparoscopic surgeries and from transabdominal surgeries to retroperitoneal surgeries, where the operative time and the recovery time is within 24 to 48 hours, and patient is able to walk by the end by the evening of the surgery with retroperitoneal approach, and the surgeons have really mastered that technique of doing retroperitoneal adrenalectomy, which is a need of the hour, because if you're looking at so many patients who would require treatment, then we need to have a lesser morbid procedure which needs to be there. There are a few learning from another different patients. This patient tells us something. So this is 38-year-old male who has hypertension and hypokalemia, biochemically proven to be having primary aldosteronism. If you do a CT scan, it shows that there is bilateral bulky adrenals, but you can see that right is not that bulky and left one is bigger. And you don't know whether it's right. So you don't know which side to operate. So that's where AVS is really required to see whether this small nodule which is sitting there is a right culprit or not, and whether the left one, the right one is completely normal. So we do a adrenal venous sampling, look at this data. Would like to simplify here that we, as I told you, selectivity index, we see whether the catheters are inside the adrenal vein or not, and it should be 5 times that of the peripheral cortisol. Both the adrenal veins have been catheterized quite well, 14 and 15. And then we look at the lateralization index when you want to divide the dominant aldosterone value with the non-dominant one, and it's 21, which is more than 4 times. So diagnosis was completely made, and it has been lateralized to the left side. So though there was a clinical suspicion, imaging suspicion of the left kind of gland which was increased, and right was kind of mildly thickened, but we didn't have a courage to operate without an AVS, and AVS give us a clear guidelines that need to go ahead, and patient has improved with that. So CT was bilaterally symmetrical and AVS was unilateral. You could get that. Similar kind of information we got for another patient. Now this lady was having severe hypertension with accelerated hypertension, pulmonary edema with biochemical confirmation of PA, and you could see that there were bilateral lesions. Here, when you look at the selectivity index, it has been catheterized well, but there is no gradient. That means it's a bilateral adrenal hyperplasia, and she was treated on medical therapy and is doing quite well. Another case of similar PA where MRI, the imaging showed that there was a right adrenal adenoma and the left small nodule, and without AVS we will not be able to really tell which was a particular part. So on this particular patient, there was a left small adrenal nodule which was secreting the aldosterone, and the right adenoma which was there, which was a non-functional adenoma, and that needed not needed to be removed. And so AVS gave us a very clear and confident diagnosis to go ahead and operate this patient. Post surgery patient is doing quite well. Learning doesn't stop. Every patient teaches us new things. This was very difficult to manage patient who was having hypertension for almost 18 years, and she needed 9 drugs to really control her hypertension, but it was not being controlled. On imaging, there was bilateral glands bulky. On AVS, we could lateralize it to the right side, and patient was treated with surgery. And histopath turns out to be nodules are there. We have a follow-up of almost 6 months. Let me share you what was the details. So post-op day 5, she was improved and the BP was well controlled only on a single drug. But in a month's time, we realized that the blood pressure was increasing and she needed to be instituted on multiple drugs. So she needed almost 3 drugs to really control her blood pressure over 4.5 months period. So it means that it was initial cure followed by resurgence, and this is a case of bilateral pathology with predominant secretion from one side. Means that the right one was dominant, and it was a bilateral hyperplasia. The right one was dominant, and after removal of that, the left hyperplasia took over, and finally she was uncured post surgery. But the dent to the aldosteronism has been made because of surgery, and the dosage of medicines have come down from 9 to 3, and she needs lesser drug, and the quality of life is better. That's why people are thinking of using surgery in case of bilateral kind of lesions is a message which can be taken from there. So when you talk of management, if you have a unilateral disease, it has to go for unilateral therapy because the treatment is gratifying with clinical success in 84% of patients, biochemical success in 98% of the patients. And if you have a lesion which is localized on one side, then that's the best candidate for going for surgery. Let's see few patients where what we have learned after going ahead with the surgery. So this lady has biochemical evidence of primary aldosteronism. On imaging, there was a single nodule there. On evaluation, she also had an ODS cortisol which was high. So this was a case of primary aldosteronism with Cushing syndrome, which is called as Cushing syndrome. It's important to know these conditions because when you operate the patient can go in post-op aldosterone deficiency as well as cortisol deficiency, and that needs to be taken care of. When she was operated, she went through a creatinine, pre-renal azotemia. On evaluation, her aldosterone was low and cortisol was quite all right, suggesting that this was a subclinical Cushing's and it was not really adrenal insufficiency, and this is transient aldosterone deficiency, which were treated with oral fluids and salt, and over a period of a month, the creatinine came back to normal. With this, you can have a stormy course of such patients, where in this particular patient, elderly individual who had diabetes and hypertension for 6 years, and he was found to have left adenoma. Post surgery, he had a very stormy course. He had to be admitted in the ICU for hyperkalemia and was treated with fludrocortisone. He is under follow for almost a year and a half, and there was suppression of aldosterone or hypoaldosteronism post surgery for almost a period of a year post-op. So underscoring that these needs to be monitored and looked for, and appropriately treatment should be instituted. This is a reality. It could be a transient, or it could be a kind of a prolonged mineralocorticoid suppressions. So what are the factors which can predict post-op hyperkalemia? Is old age, baseline low GFR, larger mass, and longer duration of hypertension, which can predict that. So we have a post-operative monitoring protocol in our hospital where we do monitoring daily with blood pressure, potassium, and creatinine, almost an alternate day for the first week, and then once in a week there. Post-op, we document that the patient has cured with lower aldosterone levels and normalization of the renin concentration. Liberal salt and water intake has been instituted. Avoid dehydration and renal toxic drugs is what needs to be done. When we talk of bilateral disease, it's majorly medical therapy with mineralocorticoid antagonists, the salt restrictions, and maybe trimethoprim and amyloid is one of the treatments which can be added on. So let's look at how do we really optimize patients of bilateral disease which require mineralocorticoid blockade. So this was a patient who was put on spironolactone and post on an amlodipine, and post starting that, renin was done. Renin was kept in the higher range or in the normal range. That's what has been advocated when we try to treat patients of mineralocorticoid receptor blockade. What has been shown in this elegant study is that they looked at patients' cardiometabolic outcomes and mortality in medically treated patients. They've compared that those with essential hypertension. It was very clearly shown that if the data is compared with surgery for unilateral adenomas, surgery is the best. But when it comes to medical therapy in bilateral part, then the the adjustment of dosages of mineralocorticoid receptor antagonist therapy, which should be adequate, is based on strong clinical follow-up, as well as potassium, as well as renin monitoring, which needs to be done. And we need to keep the renin in the normal range. If you keep in the renin in the lower side, that means the mineralocorticoid receptor blockade is not adequate. Then the cardiometabolic outcomes are really not that good. But if you keep it in the normal range, then the cardiometabolic outcomes are equivalent to that of patients who have been treated with essential hypertension. So all this while we have been talking of severe kind of primary hyperaldosteronism, where there is clinical picture, it's an overt PA, hypokalemia and severe hypertension. But more and more patients belong to this mild hypertensive or a normotensive PA cohort. And there have been data as well as literature showing that even normotensive patients who have not yet gone into hypertension have a syndrome of renin-independent aldosteronism. So it's all a spectrum, continuum from a subclinical primary aldosteronism to an unrecognized yet biochemically overt PA to an overt PA. And at least we should start looking at this overt PA in our Indian scenario. But definitely there is a case which needs to be made for looking at milder hypertension as well as those who have signs and symptoms. And that's what we need to look at. Dr. Anand Vaidya and William Youngs are expert in this field, and they are linked to health policy issues also. So we know that there are so many patients and they may not come to so many experts. And so physician needs to really look at it. It could be simplified by just doing a plasma renin and aldosterone value. And if it's less than, aldosterone is in the phase of renin suppression, aldosterone is more than 15, it really grows to the experts for managing. Less than 5, patient does not have PA, and 5 to 15, then at least the patient should be put on mineralocorticoid receptor antagonist so as to improve the cardiovascular outcomes in these patients. And those patients who progress, they may be looked for various further PA evaluation. So to summarize, I have talked about the diagnostic aspects of it. We don't need to stop the medications. Do a renin, do an aldo. If renin suppressed, aldo is high, more than 10, we can reach there. Expert centers, we need AVS before really going for managing these patients. And the treatment with MRA is really important to be managed with renin monitoring and potassium monitoring. Surgery is a treatment of choice for unilateral cases. With this, I would like to stop and thank you for your kind attention.
Hello, can you hear?
Next talk, Vijay Sarthi, sir. We would like to invite our next speaker, Dr. Vijay Sarthi.
Harshal, can you hear me?
Yeah. You are audible.
Just hold on. Please share. Yeah, Harshal, can you see my slides?
Yeah, sir, screen is visible, but the sound is cutting intermittently.
Harshal,
sir, screen is visible, but the sound is cutting intermittently.
okay, so there is.
Now it is clear, sir. Yeah.
Your network is a bit low. Would you like to take Sabah's talk first then?
Yeah.
Harshal, would you like to take Sabah's talk first?
Yes, sir.
It's fine?
Yeah.
Right. So good evening, everyone. I'm extremely sorry for this technical glitch. So now I'm going to speak on genetics of pheochromocytoma and paraganglioma from bench to bedside. We know the pheochromocytoma arises from the adrenal gland, chromaffin tissue, whereas the paragangliomas, the sympathetic ones arise from the thoracic and abdominal paraganglias, whereas the parasympathetic ones most commonly arise from the parasympathetic. Whenever we have a PPGL, I think it's very well known it behaves like a chameleon, right? Typically with respect to its clinical manifestations. But not only that, even with respect to its location, its secretory phenotype, malignancy potential, as well as for the associated features, it also behaves like a chameleon. So what can find out the color of this chameleon? So if at all, if we have a tool to detect this color of this chameleon, it's actually the genetics. A lot of advances have happened over the last few decades where we have moved from just few clinically known syndromes associated with pheochromocytoma to several somatic mutations associated with PPGL. So if you look at the genetics of pheochromocytoma, in fact, these advances have made pheochromocytoma and paraganglioma as one of the most inheritable tumor. If you look at the prevalence of germline mutations, it's almost 40%. And if you look at the somatic mutations, in another 30% of the patients we will have. So on an overall, 70% of the PPGL patients will have underlying genetic abnormalities. So that's why PPGL is called as one of the most heritable genetic disorder which in the oncology. Right. So based on the genetics, we do divide the genes of associated with PPGL to cluster 1, cluster 2, and cluster 3. Cluster 3 involves WNT signaling, and it's predominantly somatic ones, not like germline. So typically, I'm going to limit myself to cluster 1 and cluster 2, which are the typical germline mutations. The cluster 1 genes are the ones where there is involvement of the pseudohypoxia pathway. It not only includes the von Hippel-Lindau gene and EPAS1 gene, so it also includes the other genes which are involved in the energy metabolism, like succinate dehydrogenase related genes, what I'm going to refer here after as SDHX, because it includes multiple genes, including like SDH A subunit, B subunit, C subunit, D subunit, as well as SDHAF2, and also other energy metabolism pathway genes such as fumarate hydratase and malate dehydrogenase. Whereas the cluster 2 genes are the one which involve the kinase signaling pathway, typically the red gene, NF1 gene, MAX, TMM127 are the ones which involve the kinase signaling pathway. Typically, the cluster 1 associated ones present early, especially the VHL associated ones, whereas the cluster 2 related ones present a bit late. And the very remarkable difference between the PPGL associated with cluster 1 and cluster 2 is the PNMP expression, which is typically absent in the cluster 1 related PPGL. So obviously, they won't be able to form epinephrine from norepinephrine. So typically, these patients will have a normal metanephrine, whereas with isolated elevation of normetanephrine, with or without elevation of 3-methoxytyramine, which is a COMT metabolite of dopamine. Whereas cluster 2 patients will have elevated metanephrine in addition to elevated normetanephrine. In fact, like if you look at the secretory pattern in cluster 1, it is a constitutive and continuous, whereas in cluster 2, it's more of paroxysmal. And this biochemical phenotype is going to be a very useful clue in guessing or in probably and taking a clue which cluster PPGL we are dealing with. So for that, we need to have a fractionated metanephrines. Enough in one of our very early studies of PPGL, as we can see here, like we did metanephrine and normetanephrine. Normetanephrine was elevated in all FEO patients, whereas even despite being an adrenal FEO, the metanephrine was elevated only in around 19% of the patients. That's the reason where I would like to conclude that if you do only plasma-free metanephrine, it has a very low sensitivity. Why I'm discussing that? It has a reason. I usually take an opportunity to discuss this point in every FEO meeting. I get a chance where I could speak on this. Whenever we order plasma-free metanephrines, we typically get a report for only plasma-free metanephrine in most of the commercially available labs. And this plasma-free metanephrine alone is of no use for us because 80% of the times I'm going to miss the diagnosis. So what should we get then? What is more important for us is actually plasma-free normetanephrine. Even if you want to have both, so individually write plasma-free metanephrine and plasma-free normetanephrine so that you not only have a diagnosis of pheochromocytoma, and also whenever you have a diagnosis of pheochromocytoma, you can get to know which cluster of PPGL you're dealing with. Similarly, but it is a bit higher cost, maybe around 7 to 8K to obtain both of these things. But simple alternative could be urinary fractionated metanephrines. But again, there could be confusion. So order 24-hour urinary metanephrine and urinary normetanephrine separately, or at least understand from your lab that when you write urinary fractionated metanephrines, they're going to give both the values individually. The advantage of this is it's actually unlike the plasma-free metanephrines in India, which is commonly measured by ELISA. This is actually measured by HPLC, and in fact, at a pretty low cost of only around 2,000 to 3,000 per sample. So we know like using these parameters will help us to differentiate the clusters. Moving on, like we know like the cluster 1 is again divided into cluster 1A and 1B, where we have VHL versus SDHB or SDH related PPGL. Can we use any biochemical parameters to differentiate these? May not be as accurately as differentiating cluster 1 and cluster 2 using metanephrine and normetanephrine, but probably to some extent we could still do that. As you can see here, that the SDHB and SDHG related PPGL had an elevation of methoxytyramine in a significant proportion of patients, whereas it was not so commonly elevated in patients with VHL or other gene-related PPGL. So when using this methoxytyramine, in fact, 78% of the times they could accurately differentiate the SDH-related PPGL from VHL. So in fact, we are not talking much about this earlier, despite elevated methoxytyramine either in isolation or in malignancy. But however, in the current scenario, we do have labs which are offering methoxytyramine along with the plasma-free metanephrines, that too measured by LCMS, which is a very accurate assay. But again, cost may be a limitation, but probably it still gives a very good information about the biochemical status of FEO, not only to differentiate VHL from SDH-related ones, more so for prediction of malignancy. Right, so as I already told, we have worked for many decades on the genetics of PPGL. So, but the classical syndromes, what we had were NF1, VHL, MEN2, and the PGL syndromes. The PGL syndromes are the ones which occur because of mutations in the SDHX genes. Let's start with NF1. As all of you know, they will have a typical neurofibromas, scaphoid spots. But if you look at the behavior of pheochromocytoma, they typically present later in life, though we have seen even children presenting with pheochromocytoma in NF1. But the usual presentation is in 4th, 5th, or 6th decade, typically as a unilateral pheochromocytoma, predominantly almost always an adrenal tumor, and it is metanephrine occurring. So presentation is more like a sporadic pheo. So only thing you will have associated NF1 features. The second one, the von Hippel-Lindau syndrome, is one of the very important syndrome because it will have several associated features. And if you look at the associated features, there will be retinal angiomas, pancreatic cysts and pancreatic neuroendocrine tumors, cerebellar hemangioblastomas, even rarely endolymphatic sac tumor, and also renal cell carcinoma, typically clear cell renal carcinoma. If you look at the behavior of FEO in VHL, they're typically bilateral adrenal, often associated with multifocality, where there is an associated abdominal sympathetic PGL, whereas parasympathetic paragangliomas are pretty rare in VHL syndrome. If you look at the MEN2A, I think again very familiar to all of you, they will have a medullary thyroid carcinoma. Sometimes they may also produce ACTH and CRH, as you can see this lady with MEN2A who presented with Cushing syndrome because of ectopic ACTH secretion from MTC. A set of patients, especially typically with those who have 634 codon mutation, may also have skin lesions called cutaneous lichen amyloidosis. They are present in a smaller proportion, but if they are present, they speak for you that you're dealing with a patient of MEN2A. Again, if you look at the PCC behavior in patients with MEN2, they're again typically adrenal, metanephrine secreting. Most often, they will be bilateral. If you look at the MEN2B, again, the associated features would be neuromas and maybe mucosal, right? As they typically come with like bumpy lips and tongue neuromas, even conjunctival neuromas. And they will have morphonoid habitus. If you look at the corneal examination, you may get some corneal now thickening. So they may also have intestinal ganglion neuromatosis. But if you look at the PCC behavior, again, as I told earlier, this is of the similar type, bilateral, adrenal, and metanephrine secreting associated with MTC. More to the fourth important syndrome, the DHB, also called as like paraganglioma syndrome type adrenal paraganglioma, which is a very typical presentation in SDHB syndrome. But often they may also have associated multifocal disease, which could be adrenal or even head and neck paraganglioma mass. And most important feature of this is increased risk for metastasis. They're very aggressive and they will high risk of metastasis. Sometimes it may vary for up to 70%. Move on to the other paraganglioma syndrome, SDHD syndrome, also called as paraganglioma syndrome type 1. They're typically head and neck paragangliomas, though they can also have extra-adrenal paragangliomas, which may be sympathetic, as well as adrenal pheochromocytoma. The most common mutation in them is because of the mass effect, typically because of the parasympathetic paragangliomas in the head and neck. So it could be a nerve palsy or a palpable mass or so on. But be sure that like whenever you are having a SDHD associated head and neck paraganglioma, they're more likely to be bilateral. They're more likely to have an associated secretory sympathetic paraganglioma. To the data of what we had in KEM, when we did the genetics for around 150 patients with PPGL, which included both familial syndromic as well as apparent sporadic, and also variable location and number of pheochromocytoma. So we did actually not clinical exome. We limited ourselves to screen for only VHL, SDHB, D, C, and RET, because this was the project planned way back in 2008 and 9. And we also did MLPA for VHL and SDH related genes to rule out large deletions. Look at the results. There was a good yield of almost 33% of the PPGL patients at our center had mutations, the most common being VHL, followed by RET and SDHB. The prevalence of mutation, as expected, was 100% in familial syndromic cases, whereas the apparently sporadic ones had only mutations in around 16%. When we have an apparently sporadic unilateral PCC, the prevalence was even lower, which was only around 11%. When we compared our data with the rest of the world, it was similar, the VHL being the most common in familial syndromic, as well as an apparently sporadic, as well as bilateral PCC. Whereas in malignancy and among SPGL cohorts, SDHB was the most common. And this was actually matching with the rest of the world's literature. What's really differed in India was, unlike in the rest of the world, where the unilateral PCC, the most common mutation was SDHB, it was VHL with us. Again, in multifocal, where there is a combination of PCC with SPGL, the SDHB is the most common mutation outside India, whereas with us, it is still the VHL. Based on this, we designed a targeted gene approach. Again, this may not have a great relevance in the current scenario because the availability of clinical exome sequencing has become relatively cost effective, and most of them are choosing for next generation sequencing over a targeted gene approach. But there are situations where we won't be able to get a genetic testing. In that scenario, definitely this will help us to know what could be the possible associated mutation. If there's a syndromic association, it's very easy. For example, if a patient with FEO has an MTC, I know what I'm dealing with. It's MEN2. If we have a patient with unilateral PCC, most likely we may have a VHL, or rarely we may have SDHB and SDHD. If you have a bilateral PCC, if that is a metanephrine occurring, I know it is MEN2. If it is like non-metanephrine occurring, I know it is a VHL. If it's multifocal, it is typically VHL. If it is SPGL, most likely SDHB. If it's a malignant, though yield is less in our cohort when compared to rest of the cohorts of malignancy, the most common would be SDHB. Whereas if we have HNPGL, either as isolated or in association with other tumors, it's typically SDHD. We also had analysis for pediatric PPGL and their genetics. So they had significantly higher proportion of mutations when compared to adults. And compared to adults, there was no RET or NF1 mutation documented in our pediatric patients, whereas the VHL was the most common in both the groups, but it was much higher in children. The children had higher frequency of familial syndromic presentation, bilateral PCC, and multifocal disease. It's again going in line with the world's literature. So where VHL was the most common mutation in children, followed by SDHB and SDHD. Of course, we also had similar behavior. But however, in NIH series, the SDHB was the most common, probably because of like being a high-level referral center. They had a lot of patients of SDHB with malignancy being referred over there. Moving on to the bedside application of the genetics in PPGL, we know VHL syndrome has type 1 and type 2. Type 1 is typically truncating, where we don't see PPGL, whereas in type 2, it is non-truncating, where PPGL is more common. So again, we did analysis for a cohort of VHL. So, and in that study, we had around 31 genetically proven VHL patients. 81% had missense mutation, similar to the world literature, where 83% of VHL associated FEO patients had missense mutations. So typically there is missense mutations rather than large deletions. In fact, when we analyze our patients, the whole literature with large deletions in VHL, the prevalence of PPGL was very low, less than 5%. And in fact, most of the time they were unilateral and they were never bilateral, unlike missense mutation patients who typically present with bilateral PCC. Again, when you go deeper into the genetics, we see the missense mutations are the more likely to have FEO, especially those who have a missense mutation exon 3 are the ones who have the highest odds. Even if you go deeper, the one who have this C167 codon mutation, they are the ones who have highest risk of pheochromocytoma. So we know even in VHL patients, if someone has a missense, typically exon 3, typically codon 167 mutations are the one who have highest prevalence of FEO. Another interesting phenomenon we described in VHL patients is anticipation. It's a very interesting finding. In fact, we are the one who we described this phenomenon in VHL for the first time. Typically, though it's described in like trinucleotide repeat diseases, it has been recently described even in patients with autosomal dominant disorders. Here in this study, we had around 8 parent offsprings from 5 families. PCC was the initial presentation in all, and one of the offsprings diagnosed first, which is actually again making us strong to say about the phenomenon of anticipation, because most of the times it is argued that offsprings are diagnosed first basically because of family screening. But it's not the way in our study. In fact, in all the pairs, offspring was the one who was diagnosed first. Offsprings had lower age at presentation, higher number of PPGL, and also similar tumor size, though numerically it was in fact larger in the younger population. So it clearly says that there is a phenomenon of anticipation in VHL. Moving on to MEN2, again, we have this patient who presented 22 years of age with FEO, and to get diagnosed with MTC later on at 41 years of age. In fact, when his sons were screened, both of them had the mutation. Both of them underwent prophylactic total thyroidectomy despite calcitonin being normal. In fact, histopathology revealed a C-cell hyperplasia in both of them. So it's very, very important to have the mutation of RET in patients with MTC or FEO, because that categorizes or stratifies the risk of both MTC as well as FEO. Those who have an ATA highest risk mutation, that is M118T, have the highest risk of both MTC as well as FEO, whereas even M2A patients, that is who have ATA high risk mutations, they also have high risk of MTC as well as FEO, whereas the risk is lower in patients with moderate risk mutations. In those who have high or highest risk mutations, the screening for FEO should be started, if not by 8, at least by 11 years. Of course, the thyroidectomy should be considered in the first year for those who have highest risk mutations, before 5 years for those who have high risk mutations. Right, and moving on to SDHB syndrome. Again, look at this patient who presented with PGL at probably at the root of organ of Zuckerkandl at 14 years of age, treated and sent back home, but she came back after 3 years with a metastasis. So this is something which is very typical for SDHB. And then the father was screened, who also had an extra-adrenal paraganglioma. Very disheartening is that there was also another girl who died at the age of 12 years because of refractory hypertension without a diagnosis, whereas another child who is around 1.5 years of age now is also a carrier who has been closely monitored for the development of SPGL. Moving on to the SDHD syndromes. Again, this patient was 38-year-old with presented with tinnitus, decreased hear, a visible mass in the left ear. There was no family history, but he was hypertensive. He had bilateral tympanic paragangliomas and also bilateral carotid body tumors. This is something which is very typical for SDHD. There is the multiple adenic paragangliomas. In fact, this patient also had bilateral adrenal pheochromocytomas as well as another abdominal sympathetic paraganglioma. You can see this patient, wherever it is possible, he has tumors. So again, if you look at these patients, those who have truncating mutations are more likely to have high penetrance for PPGL. Again, for a non-P81L codon mutations have a higher risk for PPGL. This is another interesting thing, probably Swati would have already discussed, is like that there is a rapid enhancement in the arterial phase of the cluster 1 associated PPGL, which are non-metanephrine secreting, unlike the cluster 2 related ones, which are metanephrine secreting. So in fact, it can also give us a clue. So what kind of PPGL we are dealing with, whether it's a cluster 1 or cluster 2, even before we can obtain the catecholamines. Another importance of genetics is that, using a precision medicine for deciding the nuclear imaging choice. As we proved way back, like that there was a cluster 1 related PPGL had a higher uptake of FDG PET, but not for MIBG, whereas it's vice versa in cluster 2, where they had a poor uptake of FDG PET, whereas they had a good MIBG uptake. So again, if you know what kind of cluster PPGL you're dealing with, either by biochemistry or by genetics, you can decide what could be the choice among FDG PET and MIBG if they're the only two imaging modalities which are available with you. Even the SUV on FDG was significantly higher in cluster 1 related PPGL compared to cluster 2. But however, we have several other nuclear imaging modalities now which have come up, like DOTA, which is commonly available even to us, and DOPA PET, though it's not very commonly available. So if we have all these available with us, so if we have an apparently sporadic FEO, you can go for either DOTA or DOPA, both will work well. But if we have a cluster 1, we should go for DOTA PET. Whereas if we have cluster 2 and if DOPA is available, go for DOPA. But most of the time it won't be available, so we end up doing DOTA PET itself. But however, the two exceptions are the EPAS1 mutation and prolyl hydroxylase mutations, where DOTA doesn't do a good job. So probably here, the second best choice would be an FDG PET. If we don't have daughter, even in other SDH patients, we can still go for an FDG PET, but FDG PET is not a good test for cluster 2 PPG. Another important message we gave in our recent study, especially in children when we're doing a daughter-type PET-CT, is that this could be a very useful adjunct and detection of pancreatic neuroendocrine tumors. In fact, several lesions which were missed by the anatomical imaging and as well as FDG PET were picked up by daughter-type PET-CT. Probably we were looking for this recommendation of daughter-type PET-CT being commonly used in the surveillance of VHL children. Another important implication of this genetics for the management of POS while considering cortical sparing adrenalectomy. In fact, this is an international multicentric study initiated by Newman, in which even KM was part of. So here, typically we consider cortical sparing adrenalectomy for patients with bilateral pheochromocytomas. When we are dealing with patients of MEN2A, the cortical sparing adrenalectomy was less successful. However, the recurrence rate was significantly lower in MEN2A patients. This is the difference which we had in the study between MEN2A and VHR. To conclude, PPGL is one of the most heritable disorder with germline mutations in almost in 1/3 of patients. And of course, it genetic depends on the age, multifocality, and metastasis. The genotype-phenotype correlation in VHL and SDH depends also on the type of mutation, which exon is involved and which codon is involved. We're going more and more precise on utilizing the genetics. And genetic test helps not only in the management of a particular patient and also in the management of family members. Thank you so much. Harshal, is it audible?
Yeah, sir, you can turn off your screen. Now we call
I did that.
Our next speaker, Dr. Sabha Menon. He is Associate Professor at Department of Endocrinology. We like to invite Dr. Sabha to give a lecture.
Am I audible, sir?
Yeah, you're audible.
Good evening, one and all. I'm Dr. Sabha Menon. I'm an associate professor at the Department of Endocrinology at KEM Hospital. And my talk for today will deal with adrenal Cushing spectrum across the lifespan. I would like to thank the organizers for giving me this opportunity. Well, before we get on to the various etiologies of adrenal Cushing across the lifespan, the adrenal Cushing even has a spectrum of clinical manifestation. It can present only as a mild subclinical Cushing in which the patients have no heart signs but non-specific features like obesity, hypertension, diabetes, and osteoporosis, or they may present as florid overt Cushing in which the patient develops catabolic features. The catabolic features of skin manifestation include mooning and plethora. As we can see, there is temporal fullness and this mooning resolves after surgery. The plethora may not be visible in dark-skinned Indians, but definitely there is a change when we compare the photographs after surgery or in the patients or the prior photographs of the patients. The other clinical catabolic manifestations are skin manifestations, wherein these patients can have broad, livid, depressed striae, which after surgery fade over. The catabolic manifestations of Cushing's can even involve bone and muscles, wherein this child with Cushing's has severe myopathy and muscle wasting that he is even wheelchair bound. And the severity of the bone disease is manifested in these x-rays, wherein we can see this child is having vertebral fractures because of Cushing's, and how when he is in remission, he is actually able to walk and move about, and there is a marked improvement in his muscle and bone strength. In patients in whom we suspect Cushing, thus clinically, after ruling out exogenous Cushing's, the causes of endogenous Cushing's can be considered as either ACTH dependent or ACTH independent. As we are concentrating on adrenal Cushing and ACTH independent pathology today, but we need to understand that the adrenal Cushing's are usually only 15% of patients with endogenous Cushing's. However, this percentage is much higher in children, where almost 65% of children younger than 7 years of age can have adrenal Cushing's as the diagnosis as compared to an ACTH dependent Cushing's. In adrenal Cushing's, again, the pathology can involve both the adrenal glands, or it can be a unilateral pathology. In patients who have a unilateral pathology, the excess cortisol produced by the pathogenic adrenal will lead to suppression of ACTH and atrophy of the contralateral adrenal. In patients where we suspect Cushing's, the clinical diagnosis has to be established by a spectrum of tests, which can involve both quantitative and qualitative assessment of the cortisol axis. The urinary free cortisol is a 24-hour test which gives us a quantitative load of the amount of cortisol produced throughout the day. As it is a free cortisol, it is not affected by binding proteins. However, this test is cumbersome as it involves collection of 24 hours of urine. The qualitative tests involve the presence of altered circadian rhythm in cortisol, as we know that there is a suppression of cortisol in the evening and late night time, and hence a midnight cortisol as a serum cortisol or a salivary cortisol, if elevated, depicts an aberrant circadian rhythm. An overnight dexamethasone suppression or a low-dose dexamethasone suppression is another qualitative test of the cortisol axis, which assesses whether after giving a dexamethasone, the body is able to suppress its cortisol production or not. So in these patients with Cushing's who are florid, any test will be abnormal. But when we talk of adrenal Cushing, especially in adrenal incidentalomas where Cushing's is suspected, the dexamethasone suppression test has a higher value. It is mainly because these tests has been included in many studies, and hence the dexamethasone suppression test is a very useful test in Cushing's, in adrenal Cushing specifically. And as we know in the first talk of the day by Nalini Shah ma'am also, that the overnight dexamethasone suppression test is a highly sensitive and specific test. Coming to the history of this dexamethasone suppression test, it was established by Liddles way back in the 1960s, wherein the diagnosis of Cushing's was only driven as either being an adrenal tumor or an adrenal hyperplasia. What he realized was that when we give dexamethasone and monitor the urinary 17-hydroxycorticosteroid metabolites, all normal patients are able to suppress the urinary cortisols on a low-dose dexamethasone suppression. But when he followed this up with a higher dose of dexamethasone, he realized that patients with Cushing's disease, that is those who have adrenal hyperplasias which are ACTH dependent, are able to suppress their cortisols, whereas patients who have an adrenal tumor do not suppress the cortisols. This test is not only sensitive, but also specific, as was depicted in a study which was done in our department, in which almost 1,000 patients with type 2 DM who did not have any clinical manifestations of Cushing's were screened with an overnight dexamethasone suppression test to diagnose the presence of subclinical Cushing's in these patients. We realized that after a 1 milligram overnight dexamethasone suppression test, 96% of the patients had a cortisol level of less than 1.8. And thus, this test is highly specific in establishing the diagnosis. And these patients who did not suppress on an overnight dexamethasone suppression were then subjected to a low-dose dexamethasone suppression test over 2 days, and all these patients who had not suppressed previously now did. So we just concluded that the screening of patients with type 2 diabetes who do not have any clinical features with the use of overnight dexamethasone suppression is a very useful test. Right. In the diagnostic algorithm of Cushing syndrome, once we have established that there is a cortisol excess, the next step is to decide whether it is ACTH dependent or not. And the use ACTH as an assay becomes very useful in this distinguishing. When we analyzed a data of the last 100 patients with Cushing syndrome to decide how does ACTH behave in these different etiologies of Cushing's, we realized that in patients with adrenal Cushing's, when we consider the cutoff of 10 picogram per ml, there were still patients of adrenal Cushing's who did not have a ACTH of less than 10. In these patients, if we had gone on the basis of ACTH alone, we would have misdiagnosed these patients. And when we look into this cohort specifically, it is more of these adrenocortical carcinomas who had ACTH as high as 50 picogram per ml. And even many of these patients lied in the borderline zone of 10 to 20 picogram per ml. In our cohort in adrenal adenomas, almost all of them were below 20 picogram per ml. However, this data needs to be interpreted in the terms of clinical presentation. In a patient who has an overt Cushing, they will have a large quantitative cortisol production, and we expect that their ACTH will be suppressed. In our cohort, almost all of these patients with adrenal adenoma were those who had presented with overt Cushing, and then the test was done. It was not a patient who had presented with an incidentaloma and was then diagnosed with subjected to this ACTH test. In a patient with adrenal incidentalomas, who may just have a subclinical Cushing, their ACTH values may not be this suppressed. And when we look into these adrenocortical carcinomas, we realize that it is not even patients who have gross Cushingoid manifestations, as we can see clinical evidence of mooning, wherein we can see that their cortisol on overnight dexamethasone suppression are as high as 25 and 9, still had ACTH in the range of 30 to 50. But fortunately for us, these presentations had presented with an adrenal mass either as a complaint or had already been imaged for an adrenal mass, and we did not go on the wrong pathway of doing a pituitary imaging for these. But nonetheless, missing out an adrenocortical carcinoma in a patient in whom ACTH is elevated will be indeed a disaster. And hence, whenever we have a patient of a Cushing in whom the ACTH levels are not less than 10, we should at least get an ultrasound of the adrenals so that we are not missing out a large adrenocortical carcinoma sitting there. The other aspects of an ACTH test are that this test also depends on the laboratory platforms on which it is done. When we look at this is a sample report of an external quality assurance of an ACTH test. As we can see, when we look at the Siemens machine, when we have a sample of ACTH, when we compare it over all the machines, the mean value comes as 14.9. When this sample is run over Roche, the mean value comes as 9.59, whereas on a Liaison platform, the ACTH will be read as high as 32. And thus there can be a negative or a positive bias, and this sample, which has an ACTH of only 14.9, will then go ahead in the direction of an adrenal ACTH dependent Cushing if we are reading on a Liaison platform, or an ACTH independent if we are reading on a Roche platform. And hence it is imperative that whenever we read this ACTH, especially those ACTH which are on the cusp or borderline, we should always repeat an ACTH, and also we should look into the platform which we are using. If we are using Liaison, we should be aware that the ACTH can be on the slightly higher side, and this platform has an inherent inherent positive bias in the interpretation of ACTH. The another caveat in ACTH use is its lability. As we understand that in patients wherein the ACTH sample was stored and analyzed after a few hours, the value of ACTH which was measured decreased as a percentage of baseline at 48 hours to being almost zero. So if we collect a sample of ACTH today and we are reading it after 2 days, we can get a zero ACTH, and even a patient with a pituitary Cushing may be misdiagnosed as an adrenal Cushing. So what we need to understand is that ACTH is more stable in a plasma as compared to serum, and hence we should always use an EDTA bulb for collection. Again, a refrigerated sample will have a better stability as compared to a sample on a room temperature, and we should try to expedite the analysis of this ACTH test. As an alternative to ACTH, DHES is a test wherein, as we can see, it can be used as a marker for ACTH. ACTH has a half-life of 10 minutes, whereas DHES has a prolonged half-life of 10 to 16 hours. As in using an analogy of diabetes patients, ACTH can reflect a fasting sugar, whereas DHES is the HbA1c equivalent. As we can understand in this paper, where LCM steroid profile of Cushing's was done, patients who had adrenal Cushing's had lower values of DHEAS, DHEA, and androstenedione, reflecting that the lower ACTH leading to lower adrenal androgen production, whereas patients with pituitary or ectopic Cushing's will have higher values. Nonetheless, this value for adrenals is of an adrenal adenoma. In patients who have adrenal Cushing's, they can be androgen secretory and can have higher DHEAS as well. So this caveat of using DHEAS as a marker for ACTH is only applicable in an adrenal adenoma and not an adrenal Cushing. Once we have used and understood the various caveats of using ACTH, we will then move on to anatomical imaging of the adrenals to localize the type of adrenal tumor. So as CT scan or MRI are modalities which can be used, and we routinely prefer to use CT scan to understand the anatomical pathology. The CT scan can give us the idea whether the pathology is unilateral or bilateral. By far, unilateral pathologies are more common than bilateral. So if we were to look at an adult with Cushing's, approximately amongst the 15% of adrenal Cushing's, only less than 1% would have a bilateral pathology. And amongst the adrenal adenoma and carcinoma, 5% will end up with adrenal carcinoma and 10% with adrenal adenomas. But when this statistics is looked after in children, amongst the 65% of patients with adrenal Cushing's, 50% of children less than 7 years will actually have an adrenal carcinoma, and only 15% will have a benign diagnosis. So the CT scan can help us understand if there is a single or a bilateral pathology. And even among single pathologies, it will help us delineate whether it is a benign or a malignant pathology, as we understood in the talk on CT scan by Dr. Swati ma'am, as in how enhancement patterns, size, and the presence of necrosis or calcification can distinguish between adenomas and carcinomas. Bilateral pathologies can be either micronodular or macronodular, and by means of micronodules, we mean that the swelling, the tumors are less than 1 centimeter in size, and macronodular tumors are more than 1 centimeter in size. Coming to the spectrum of adrenal Cushing across the lifespan, as we can see, each different age group has each different flavor of the etiology of adrenal Cushing's. The infancy and adult, in both the extremes of age, we can have presentation of adrenal cortical carcinoma. Coming to the childhood, PPNAD can present in childhood. This was the first case of PPNAD seen in our department. He is a 4-year-old child who presented with a 1-month history of weight gain, puffiness, hypertension. And as we can see on examination, he had lentigenes on his eyes. On biochemistry, he had clearly suppressed ACTH and a low-dose dexamethasone suppression test, which was not suppressed, and on a Liddell's test, he had a paradoxical increase in the urinary cortisol after an HDDST. His imaging was done and the MRI adrenals were normal, and we should understand that in patients with PPNAD, the adrenals can actually be normal on imaging. We looked for echocardiography and associated thyroid and testes, which were normal in this patient, and thus he was diagnosed as PPNAD. He underwent surgery, and the gross specimen and the histopathology showed nodular hyperplasia with intervening areas which were atrophic, and he did not have any pigmentation. So PPNAD patients can also have nodules which are not pigmented. On follow-up, we can see that he was on hydrocortisone and fludrocortisone replacement, and he was growing well. This was a cohort of PPNAD patients which we had published recently, a childhood presentation in which the youngest child of ours presented at 15 months, and they had varied spectrum from being a cyclical Cushing to overt Cushing and hirsutism as a presentation. One patient had a familial case. All of these patients had clearly suppressed ACTH, which was kind of expected because all of them are overt Cushings. And on imaging, some patients had typical beaded appearance of adrenals, whereas some others had normal looking adrenals. The histopathology in 2 patients showed pigmented nodules, while in the remaining 3, the nodules were not pigmented. This could probably be because of the younger age of presentation of these patients. Not all patients had associated manifestations. 3 patients had only isolated PPNAD as presentation, whereas the remaining 3 had lentigens as well. And the genetic analysis for these patients was also done, which was positive in the Prakar gene for 3 of these patients. The familial patient, when traced back, we came to know that there was an aunt who was almost 40-year-old who was just going on as being managed as diabetes and hypertension, and the consideration of adrenal Cushing and PPNAD was not even thought of until the index patient was diagnosed. Amongst these family, these 2 other patients underwent adrenalectomy, and these 2 patients just had lentigens and are just being on follow-up. When we come to the pathophysiology of the PPNAD, the ACTH acts as a first messenger, which then through a G protein coupled receptor leads to an increase in cyclic AMP, which is the second messenger. And this cyclic AMP will then lead to increase in protein kinase A catalytic subunit, which is the third messenger. In these patients of PPNAD, the regulatory subunit is dysfunctional, and hence there is a marked increase in the catalytic unit, which then leads to a decrease in ACTH and decrease in cyclic AMP. When we come on to the adolescents who can manifest as adrenal adenoma, as is this young 17-year-old girl, where ACTH was less than 5, with an ODS of 19.3, which was clearly unsuppressed, and MRI showing a clean hypodense nodule of 2 centimeter, which was a cortisol secreting adenoma. She undergoes surgery, and we can see the marked difference in her clinical features made after the surgery. In these patients with adrenal adenoma, they have somatic mutations which can lead to formation of adenomas, like the catenin mutation or mutations in the catalytic subunit of protein kinase A. When we come to adults, they can have adrenocortical carcinoma. For example, this patient who presents with Cushingoid features with gynecomastia and hypertension, which leads to an ultrasound, and he ends up with a mass. And on investigation, he has a suppressed ACTH and ODS of 49 and an elevated estradiol, which has led to this gynecomastia. So he is a patient with cortisol and estradiol secreting adrenal mass who has a lesion confirmed on CT with no evidence of metastasis on the FDG PET scan. When we look into these patients with adrenal cortical carcinoma, according to the NSAD grading, they can have stage 1 to 4, in which the patients with stage 4 have distant metastasis, and unfortunately 40 to 50% of patients with adrenocortical carcinoma present with distant metastasis. And the survival also depends on the NSAD staging, wherein these and the eventual 5-year survival is almost 35% only in these patients. For management of these patients, surgery is the best chance for these patients. The patients who had an R0 complete resection had the best survival as patients as compared to patients who had no surgery. The surgery should be done in an experienced tertiary care center, respecting the oncological principles, and even the lymph node should be resected. This patient underwent surgery and was a adrenocortical carcinoma stage 3 as he had infiltration into the adjuvant tissue. And now he would thus require adjuvant therapy. He was given radiotherapy and subsequent follow-up. He was in remission. But then 12 months down the line, he started developing elevation of estradiol levels, and an FDG showed a node which then progressed to multiple metastasis and elevated ODS cortisol. He was then advised mitotane, which he was not affording, and he underwent 3 cycles of chemotherapy. When it comes to the use of mitotane, there are certain caveats which we need to understand. Obviously, monitoring for safety of mitotane is inbuilt, that is the monitoring of liver functions test and the complete blood counts to look for cytopenia should be done monthly and even 3 monthly. But the hormonal monitoring is what we as endocrinologists can enhance the care for these patients. Mitotane is an agent which will lead to decrease in adrenal hormones by increasing the cortisol binding globulin, by altering the metabolism of CYP3A4, as well as causing an adrenolytic effect and atrophy of the adrenals. Hence, these patients can undergo not only cortisol deficiency but also mineralocorticoid deficiency. And for monitoring of cortisol levels in these patients, a serum cortisol is of no use because they will have an elevated CBG. We need to actually do a urinary free cortisol in these patients, and even ACTH can be monitored and kept between 1 to 2 times the upper limit of normal on replacement. These patients may require monitoring of renin and electrolytes to understand for any evidence of evolving mineralocorticoid insufficiency, which can then be replaced. For monitoring of thyroid hormones, similarly, an elevated in thyroxine binding globulin can lead to falsely elevated total T4, and hence free T4 and TSH are required for monitoring. And similarly, these patients can have falsely elevated total testosterone levels, and the use of SHBG or free testosterone will enhance the value. And in these patients, the requirements of the replacement hormones can be as high as 120 milligram of hydrocortisone instead of the 15 to 20 milligram which we give usually. They might even require as high as 300 micrograms of levothyroxine to keep the TSH in the normal range, and even 200 milligram weekly of testosterone to keep the free testosterone in normal range. And we should be aware that these high doses can be needed in these patients. In adrenocortical carcinomas, the pathology lies in chromosomal aberrations, wherein they can have increase in IGF-2 pathway, or they can have a mutations in the P53 or the beta-catenin pathway, which can lead to the development of these malignancies. When we come to the elderly age group, we have this young lady, this lady of 57-year-old who presents with weakness and on CT scan has bilateral nodules, which are hypodense with good washout, and she has a suppressed ACTH. Even on just monitoring, her values remain nearly the same. There is no increase in size, and the cortisol is just lingering around. In these patients with macronodular adrenal hyperplasia, they can be germline as well as somatic mutations in ARM-C5 gene, as well as other genetic mutations like MEN1, fumarate hydratase can also be present. This is a 70-year-old who was incidentally detected to have an adrenal mass on imaging done for an urinary complaints. Although his ODS cortisol was only 3.45, he had elevated late-night salivary or LDDS cortisol, and he also had osteoporosis on DEXA scan. So this elderly gentleman has an adenoma with a subclinical Cushing, and he was subjected to surgery and had a stormy post-operative course when he actually had herniation of bowel requiring surgery, ventilatory support, and wound dehiscence. Post-operatively, His histopathology showed an adrenal adenoma, and eventually he had a resolution of this cortisol excess. He had a loss of almost 8 kgs of weight, and we can see the marked difference in his clinical presentation. His antihypertensives and anti-diabetics reduced. But when we talk of this etiology of subclinical hypercortisolism, the terminology is now gearing towards the use of autonomous or possible autonomous cortisol secretion. These patients can usually just present with these mild non-specific features, and on dexamethasone suppression, if they have an overnight dex suppressed cortisol of more than 5, they will be called as an autonomous cortisol. A dexamethasone suppression value of less than 1.8 rules it out, and between 1.8 to 5 will be labeled as possible autonomous cortisol secretion. These study showed that they can have some increase in all-cause and cardiovascular mortality as compared to patients with adenomas who do not secrete cortisol. However, due to small event size number, this data is not as representative. The management of these patients is mainly geared towards understanding the severity of cortisol excess. Patients with more than 5 of dex suppressed cortisol will be more warranting surgery rather than patients with between 1.9 to 5. Similarly, the comorbidities dictate the management. A patient with subclinical autonomous cortisol secretion on surgery have improvement in antihypertensive and antidiabetics as in our case, but the improvement in cardiovascular mortality or bone manifestations has not yet been shown in studies. Thus, to conclude, patients with adrenal adenoma can present as overt manifestation who should and definitely will benefit from a laparoscopic surgery. Patients with autonomous or subclinical Cushing's will require individualized treatment based on the severity and comorbidities, and post-op steroid replacement is a must. In patients with adrenocortical carcinoma, the need for open surgery, especially in tumors more than 6 centimeters, adjuvant therapies for stage 3 and stage 4 tumors, and multidisciplinary care is the need of the day. Patients with PPNADs should undergo bilateral adrenalectomy and be on post-op lifelong steroid replacement. Not only that, the screening of their family members and the patients per se for other syndromic components is a must. In patients with macronodular hyperplasia, the treatment should be individualized. Thank you.
Thank you all speaker for excellent and expertise talk. I am thankful to Dr. Pramod Gandhi sir and Dr. Pramod Shah sir for chairing this session. I would like to conclude this session. Any questions are remaining, or we should conclude the session?
I don't feel there are any questions on the chat box.
Yes.
Yeah.
No questions, sir.
So,
Should we conclude?
I think we should thank all the speakers of this session, and also thank the organizers for giving this opportunity. On behalf of me and Dr. Paraksha, I thank organizers.
Thank you.
Good night. Good night, everyone.
Good night.
Good night.
Thank you.
Thank you, everyone, for joining for this session, and we would welcome you all to join tomorrow in Hall A for the surgical session on thyroid and parathyroid disorders. All the surgeons.
Reason which have been run. But if we don't, then the patient will have to keep on going for threading, waxing, laser, and different kinds of treatment, which then could be quite distressing.
There's some cross connection.
Yeah. I think I would like to thank chairpersons Dr. Gandhi sir and Dr. Parag Shah sir, as well as we like to thank Dr. Harshal as well as Dr. Amol and Dr. Virendra for conducting the session wonderfully. And I would like to thank Endocrine Society of India for giving this opportunity. I think a good night, everyone, and have a safe day ahead. Thank you.
Good night. Good night.
Thank you.
Thank you.
Thank you.
Thank you.